Well, welcome everyone at the Duchenne Care Conference 2023. My name is Suzanne. I will be your host for the upcoming 2 days. So the agenda for today, and I will also share a link with you in the chat about this. Of course, Elizabeth will do the welcome, but today we will focus on 3 important topics. We will start with a session on females with dystrophinopathies. We will then be followed by a session on cardiology, and we will end with an interesting session on endocrinology in DMD. So with nothing further ado, I'd like to hand over the floor to Elizabeth Vroom, the chair of the World Duchenne Organization and criminal mastermind behind the Duchenne Care Conference. Elizabeth, the floor is yours.
Thank you. The line was a bit wobbly for a second, but welcome everybody to this conference, the Duchenne Care Conference 2023. It's really amazing that so many people signed up, because if you remember or know, the mission of the World Duchenne Organization from the early days is that there is a compelling need to ensure that wherever we are, patients and families, everyone really diagnosed with Duchenne and Becker muscular dystrophy can benefit from standards of care that is confirmed by the best practice of clinicians, of the best clinicians even from all over the world. And it's equally important that this information is available to families and clinicians, healthcare professionals, is contemporary, truthful, and based upon the latest research. So this makes this meeting such a wonderful moment to share the best practice of the best clinicians, and also that it is based upon the latest research. So we're very happy for that. And I also want to thank all the speakers that they will be, that they are here today. And these are the most amazing speakers, and everybody said yes. Even the people who couldn't make it in person were so kind to pre-record their presentation, so you will still be hear their stories, and maybe not at this moment ask the question, but you can still have the questions asked, responded to later. And I think last but not least, it's important to realize that as today we will have patients of healthcare professionals from 67 countries. And if you realize that the United Nations only recognizes 195 countries, and 35% of all states, even the smaller states around the globe, are presented today. And you all together, we all together online, are the ones who can share the message with others, because we can have this mission, like we want everybody to get the best care, but only the people in the countries themselves can do it, and also spread the message at the national or regional level. So we are very grateful that you signed up in such a large number. This is really amazing. And then standards of care, maybe Suzanne has the next slide for me. The standards of care were published, the last ones, in 2018. And in fact, everything also we discussed today is based, this is the basis for our current vision on the standards of care. However, as we said, standards of care and information about care also needs updates, new insights, or maybe expand a little bit on certain topics which were not so much, not so elaborate in the standards of care. So that makes that today we will have a lot of topics which are not in the same detail in the care considerations. However, these 3 papers are still kind of the basis. Meanwhile, we do have, like, Professor Ross-Quinn-Liven is following this slide, and she also published with a group from the UK, the care considerations for adults. There is now work on females. So there's a lot of new information, and we are very happy to share that with you today. So it is my great pleasure to introduce Professor Ross-Quinn-Liven, Professor in Neuromuscular Diseases of the University of London, and the floor is yours. Okay.
Lovely. Thank you very much, Elizabeth. Thank you. And it's a real pleasure to be here. Thank you very much for inviting me. I'm just going to share my screen, and I'm going to talk about care for females with dystrophinopathies, which is a new topic, I think, for all of us, really. These are my disclosures. And actually, my talk is going to be based particularly on a recent ENMC workshop, which took place in May last year, so just over a year ago, where we tried to refine recommendations for prevention, diagnosis, surveillance, and treatment of female carriers with dystrophinopathy. And really what came out of this workshop is how little evidence is there in the scientific literature for female carriers. So you'll all be aware of the spectrum of dystrophinopathies, from the mildest Becker patients who present with cramps and myoglobinuria or anesthetic-induced rhabdomyolysis, to right the way through to Duchenne dystrophy, obviously the most severe condition, and there are grades in between, intermediate phenotypes. And so when we're talking about carriers of dystrophinopathies, we're really talking about carriers of the whole spectrum, really, both Becker and Duchenne. What does it mean to be a female carrier? Well, for dystrophinopathy, majority of women who are carriers, who carry the dystrophin gene, are completely symptom-free. But there are a number of women who may have one or all of the following symptoms. They might, for example, present with a persistently high CK or even abnormal liver function tests because the liver enzymes, the transaminase, are coming from muscle tissue, or they may present with muscle symptoms, muscle pain, and muscle weakness. More importantly, and more commonly, there may be cardiac involvement. And it's also really coming to light that in a small proportion, but we don't know how many, there may be cognitive impairment. Diagnosing a woman as a carrier for Duchenne or Becker muscular dystrophy has profound implications for that woman and also for her wider family. So it may involve then testing her mother or her sisters. There may be young boys at home who haven't been tested who might be affected with the condition. There may be aunts, there may be cousins, there may be a wide number of people who this diagnosis may impact on. And so actually receiving the diagnosis for the woman herself also has profound implications for her future family planning. And so we need to differentiate between women who are carriers and completely asymptomatic, and girls and women who actually have a muscle condition. So we would now like to call these females with a dystrophinopathy. And this is a young girl I saw many years ago at the age of 8, who was thought to have an inflammatory muscle condition because she presented with pain in her calf muscles. You can see here one calf muscle is much larger than the other calf muscle. And in fact, when she had a muscle biopsy, I'll just go back. You can see this is a normal muscle biopsy where the dystrophin is expressed on the outside of the sarcolemmal membrane. This is a Duchenne muscle biopsy where dystrophin is absent. And this is the biopsy of a female with dystrophinopathy where there is a mosaic appearance. So some fibers contain dystrophin and others don't. Now, why does this happen? This happens because of a phenomenon known as X inactivation. So in every female cell, there will be 2 X chromosomes, but one of those X chromosomes has to be switched off at any one time. And this happens randomly. So if you like, these are the 2 types of X chromosome, brown and white, and they're randomly switched on or off. And about 50-50 of these X chromosomes should be switched on or off. But sometimes a proportion of the abnormal ones may be greater than the proportion of the normal ones. So in our center, we undertook a retrospective case note review of 13 symptomatic women with a dystrophinopathy. The mean age of those women was 37 years, but their ages range from 18 to 55. 46% of those women had no family history of Duchenne muscular dystrophy. Their serum creatine kinase ranged from just above normal at 237 to really markedly high at over 6,000. And almost 40% of those women complained of muscle pain and muscle fatigue. 30% reported low mood and or anxiety symptoms, and 2 patients or 15% reported chronic bowel symptoms. And one of those ladies had quite moderate learning impairment and went to special school and was attending a special college. And 2 of these females had autistic spectrum disorder. 4 of these women were non-ambulant. 2 had lost the ability to walk following prolonged intensive care admissions for infection and respiratory failure. And 2 of the women lost the ability to walk following lower limb fractures, both hip and distal femur. And 1 woman, sorry, that should be 5 actually, were non-ambulant, lost walking due to progression of muscle weakness. More recently, we've had a patient who's presented to us with a metabolic phenotype, rather like the Becker muscular dystrophy phenotype, with acute rhabdomyolysis, muscle pain and fatigue, and a persistently raised CK. So if we look at some of the cardiorespiratory features of these women, what is quite interesting is that they're quite different from adults with Duchenne or boys with Duchenne on Becker dystrophy, in the sense that the cardiac and the respiratory involvement doesn't always follow the same degree as the muscle involvement. So 2 of our patients required non-invasive ventilation, one of whom was still walking at the time. And you can see that some of these women had quite markedly reduced vital capacity, even though they were ambulant. In addition, over 50% had evidence of cardiomyopathy. Now, this is not symptomatic. It was picked up on routine screening, which, as you know, is in the standards of care. But as you can see, it was quite prevalent in this population. Again, interestingly, 3 of the women, all of whom were still ambulant, reported bulbar symptoms, such as choking or food getting stuck in the back of their throat, taking longer to finish a meal, and sometimes presenting with jaw pain and fatigue with chewing, or needing to wash down food with a drink. 5 of these women had been treated with steroids. 2 of them had stopped steroids mainly due to side effects, which particularly were weight gain and mood swings. But 1 woman decided to continue steroids despite developing cataracts because they're of benefit. And those 3 women who remained on steroids reported benefit. All of the women who had steroids reported a decrease in falling over and a preservation of muscle strength and reduced muscle fatigue. Again, the musculoskeletal effects seen in these women were usually asymmetric. All of them had lower limb muscle weakness, and some of them had proximal and distal weakness. 60% had weakness of the trunk muscles, and 4 of the women had calf hypertrophy and some contractures. So if we go back to the standards of care that Elizabeth was talking about, what they do describe is that for women with a dystrophinopathy, timely diagnosis is essential, and they recommend regular cardiac evaluation. Now, these are the standards of care for Duchenne, and actually they probably do need to be adapted for women and managed according to the needs of the individual, because as I've shown you, some of the women that we've seen with muscle involvement present in very different ways and have a different pattern of weakness to men. The other thing is that for siblings, female siblings of boys with Duchenne, timely diagnosis is really essential, and that may mean early diagnosis, particularly if there is some cognitive involvement. And certainly from the ENMC workshop, it appears that there may be some women, as with one of ours, who present early with developmental delay, and those girls may benefit from appropriate intervention. And all women with who are carriers of Duchenne should be referred really at the point of diagnosis for cardiac evaluation, and that should continue throughout their life. So these standards of care could be used for women, but they definitely need to be adapted to the individual needs. So at the workshop, Elizabeth presented the results of a very interesting survey. She asked women who are carriers what services they would want and expect. Interestingly, although the standards of care recommend regular cardiac follow-up, this was only available in a third of countries. So that's quite surprising, really. So many women are not getting regular cardiac follow-up. The key expectations of women were that they would like earlier genetic testing, particularly of the sisters of boys with Duchenne, that all women would like regular follow-ups and regular checkups, and very importantly, 77% said they would like psychosocial support and counselling, and this was only available for a third of those women who responded. And so these responses came from 20 different countries, and so it's quite clear that health services for women with dystrophinopathies are lacking. Also, carriers of Duchenne and Becker dystrophy wanted to be assessed and managed in their own right, rather than being in the context of being a mother of a Duchenne son. And definitely, as I've already said, access to psychosocial support was very important. So these women not only have to deal with the consequences of carrying the Duchenne gene and caring for their son, but they also have physical involvement themselves. So they have a lot to contend with. Teresina Evangelista also presented a Euro NMD survey of female carriers. And in this survey, there were 94 respondents. 71% had their genetic status confirmed, and the mean age of them being tested was 21.4 years, although the range was 7 to 54 years. Again, rather like our cohort of patients, a third reported muscle symptoms, muscle pain and or weakness, muscle fatigue and general fatigue, and cardiac involvement. But only 25% had attended a specialist neuromuscular clinic, and only 53% had attended a cardiology clinic regularly. 74% had received genetic counselling. So again, this demonstrates a lack of services for females who are carriers. And again, rather like our cohort, 3 of these women were wheelchair users and 1 used non-invasive ventilation. So what is lacking for females? As we've already alluded to, psychological support from the time of diagnosis, and it should be there throughout life for times of need. There should be, women are not able at the moment to access therapies. They should be able to access corticosteroids. Perhaps we need to do a trial, but there's very limited natural history data available to inform the best outcome measures. And as I've shown you from our cohort, because of the random muscle involvement that occurs in women, it's very important we try and find the right outcome measures to do trials. And again, women are not able to access ataloran at the moment. And the other question is, at what point should they start heart protection treatment? So I think it's fair to say that women with a dystrophinopathy are a fairly neglected group of individuals. Many, as I've said, will also be carers for their affected sons. The standards of care for Duchenne dystrophy should apply and could be very helpful in managing these women, but they need to be adapted. For example, an ambulant woman might still have bulbar symptoms, and she might still have very significant respiratory involvement and have need for non-invasive ventilation. So you cannot follow the standards exactly as they are for males. 100% of women should be accessing cardiac support. I think what came out of the workshop was that referring to women who are affected with muscle symptoms as being manifesting carriers undermines their symptoms. And women want and need to be treated in their own right. So it was felt that the best term to describe these women was that they are women with a dystrophinopathy. There is a desperate need to develop international registries so that we can understand the natural history further, because without this information, it's going to be very hard to inform clinical trials. So finally, just to summarize my talk, all female carriers of Duchenne and Becker dystrophy, regardless of whether or not they have symptoms, should be offered psychological support from the time of diagnosis, and they should all be offered cardiac follow-up. Women with dystrophinopathies are probably underreported. I suspect many women are so busy caring for their sons and their families that they don't report their own symptoms. There needs to be an increased awareness amongst physicians, because some women, in fact, quite a high proportion, will have no family history of Duchenne. So we need to think about dystrophinopathy when women present with symptoms that are asymptomatic or with other muscle symptoms, because this is one reason why diagnosis may be delayed. The Duchenne standards of care are helpful, but they must be adapted to be appropriate for females. Genetic testing of sisters of Becker and Duchenne boys should be considered at a younger age. And this is something that the families really wanted from those surveys. Also, you know, it's good practice to test any boy who's presenting with developmental delay for Duchenne dystrophy. And we should consider testing girls as well, as some of these girls may be carriers, or maybe girls with dystrophinopathy. And finally, we need to better characterize the phenotype. Again, this may help with clinical trials. And it's quite possible there may be females out there who have only cognitive impairment, but we don't know because we're not testing. And so what is really needed here is an international natural history registry to try and collect data to understand the natural history of this condition. And I'm going to stop there, but acknowledge my co-organizers of the ENMC workshop. That was Anna Sarkozy, Alessandra Fellini, and John Burke. A huge thank you to Elizabeth A for inviting me to talk today, but also for her survey of women carriers, and Teresina, who also did the Euro NMD survey, and Alex Petrus is my PhD student who collected data on our cohort. And I've listed the other members of the workshop because I think this was a really, really useful workshop, and the report is available for anyone who wishes to read it. Thank you very much.
Thank you so much, Professor Quinlivan, for this amazing talk, and also for being such a good teacher. Everything you tell is clear. We really love to hear your thoughts on subjects, and not only adults and females, but also other subjects. But this is amazing. And I want to thank you again. I also want to thank you for setting up this workshop, or being one of the co-organizers. And as everybody might have seen in the list of participants, there was also Saskia Houwe. And Saskia Houwe is our next speaker. And this year there is more attention also in the program for females with dystrophinopathies, because we had last year in 2022, the World Duchenne Awareness Day about women and Duchenne. So for this reason, there are today 4 speakers in total about women with Duchenne. So I would love to announce the next speaker, and that is Dr. Saskia Houwe. She was also in that other meeting, but she has amazing data about girls, really younger cohorts with Duchenne, or dystrophinopathy, we should say. And the floor is yours. Thank you so much for presenting today.
Okay, well, good day, everybody. Welcome to this great care session. And Elizabeth, thank you for organizing this. And well, after a very inspiring and also recognizable session from Ross Quinlivan, it is my honor to tell something about the cohort of girls with dystrophinopathy who had symptoms before the age of 16. Before I will continue, I will introduce myself. My name is Saskia Houwe, and I am a pediatric rehabilitation physician at the Radboud University Center of the Netherlands. And this presentation, we will zoom in on the characteristics and symptoms of the girls, but also on their activities and participation. This is our cohort. The cohort we have seen in our center consisted of 12 females. The median age on the onset of symptoms was 4 years old. The median age of age of diagnosis was 8 years old. And at follow-up visit last year, the median age was 23 years old. Only 2 of the 12 girls had a positive family history and all had a high CK. One of the participants deceased due to cardiomyopathy, and she was non-ambulant and could not raise her hands above her head before she passed away. And the other 11 patients were seen during a follow-up visit. First, we collected the baseline characteristics of all the patients retrospectively. We had contact with the family of the deceased patient, and all other patients visited our outpatient department. During the visit, anthropometrics were measured, cardiac assessment were done, spirometry was done, and we performed functional assessments such as the Brook and Vignes scale, the North Star ambulatory assessment, and the goniometrics. Also, we did a semi-structured interview asking about symptoms and comorbidity. And moreover, the participation was assessed with help of the Utrecht scale of evaluation of rehabilitation participation. You use a PAY, and we asked them how their care management was arranged. While looking at the baseline characteristics, we found differences in symptoms depending on timing. On the preschool onset of the symptoms, we saw delayed milestones, speech development, motor development, and cognitive development, just as Ross was also saying. And this is also similar with the boys who are early assessed, and also feeding difficulties were seen. In the preschool onset, we see more exercise intolerance, fatigue, and myalgia. And they just said, well, I couldn't keep up well with my age peers. Also, the diagnostics were different. There was no unified diagnostic pathway. Most of the time, the high CKs were a clue to seek more, but not all complaints were taken seriously from the beginning. In one case, a diagnostic examination was done after the birth of her 2 sons with DMD. So it was a little unclear and not unified diagnostic pathway. During the follow-up visits, we did medical assessments, and only 3 patients had minor abnormalities on the ECG or ultrasounds, and they had no symptoms. The respiratory function was lower than 75% in 7 out of 10 patients, and 1 patient had a lung function of 17%. And also one was having an exercise intolerance, and she understood that because of her lung function, maybe this was explained. And now she has training under supervision of a physiotherapist. The other one with the lung function of 17%, she went to the she went for the home ventilation, and now she's fine. But she had also complaints of shortness of breath and lacking temperature. So this was, but she was not taken seriously, and that's why this is important to notice. 3 out of the 11 participants had cognitive impairments, and they needed special education. And the functional assessments were displayed. More than half of the patients were maximum ambulant. 1 was fully wheelchair bound, and 4 others have had difficulty walking. We also saw contractures, such as seen in males with Duchenne muscular dystrophy, but then we saw more asymmetric contractures. We checked the presence of a list of symptoms, and here you see the percentage of the symptoms who were most prevalent in the dark bars. And in the light bars, you see the participants gave a score on how the symptoms were burdening in their daily life. And as was seen, fatigue, myalgia, backache, arthralgia occurred in more than half of the females. And it also had a very high constraint in daily living. Other prevalent and burdening symptoms were daytime sleepiness, constipation, obesity, coldness of feet and hands. This burden also translated to the restriction in social participation. Here we see the percentage of the perceived restrictions in participation caused by the disease. We see in this cohort that it's most restricted in occupational duties like household activities, work, and education. 3 of them had a paid job, but all 3 had a full or partial disability allowance. The participants all experienced lack of knowledge and also that they had to fulfill in occupational duties. At last, we asked them which caregivers are involved in their disease course. And all of them had seen a neuromuscular specialist the past year, but we also realized that this cohort was identified in a neuromuscular center. So I think we have a little bias there. Cardiac care was arranged for all participants, however, 2 did not receive it the last 5 years, and only 2 of the patients have seen a pulmonologist, which was indicated during a visit at the neuromuscular specialist. 3 out of 11 patients had seen a rehabilitation specialist, and only 1 of the patients regularly visited a physiotherapist. We think that with the problems which were described in participations and the numbers on decreased respiratory function, more attention should be on these fields and taking care of the girls with dystrophinopathy. After investigating this cohort, we believe that acknowledgement of the symptoms is the first step in taking care of the girls with dystrophinopathy, so that we have a better view on what to expect and that they can know where to ask for help and support. Moreover, we recommend that every girl who has a mutation in the DMD gene and reports symptoms is also seen by a neuromuscular specialist. From there, a low threshold additional respiratory screening can be indicated, and if participation is restricted, a rehabilitation physician can help in the support of these girls. I hope this cohort can enlarge awareness among all of us, and the next girl with dystrophinopathy is better supported during her disease course. Thank you very much for your attention.
Thank you so much, Dr. Saskia Houwen, for your presentation on this girls cohort. And we will now continue with the next speaker, but then at the end of that talk, we will have ample time to discuss questions for you and the other speakers. Thank you again. So then the next speaker is Dr. Karolina Podolska. She's the care manager of the Duchenne Parent Project in the Czech Republic. And she will discuss with us how Duchenne mothers behave or adhere to healthcare and self-care. So there have been some studies, and Karolina will kind of put this nicely together. Thank you, Karolina. Go ahead.
Thank you. Hello, everyone. I hope you can hear me well.
Yes.
Thank you, Suzanne, for the presentation, and thank everyone for being here, but WDO for inviting me to speak. So my topic today is Duchenne mothers. I will talk about 2 groups in particular, about carrier mothers and about caregivers. I would like to state at first that when we will talk about caregivers, it doesn't only apply to mothers, but also to fathers who take care. So first of all, I will just share what we know about these groups, then concerns when it comes to healthcare, and then we will talk about data that is available, and I will suggest a few things that might come in handy for doctors taking care of these groups around the world. So as Professor Quinlivan already mentioned, carrier mothers are at higher risk of cardiomyopathy, muscle weakness, possible cognitive impairment, but also dyslipidemia. There has been a paper on this, that there might be a primary type of dyslipidemia not yet recognized before, And we do see that in carrier mothers and in some Duchenne boys. Just see that I do refer to some articles that this presentation is based on. So if you wanted information on that, it will be on one of the last slides. The other group, caregivers, is equally as important. It is a much bigger group because it involves, of course, carrier mothers as well. And there has been a paper that was given to Congress, to United States Congress, to discuss when a new act was coming up that shared that there's high risk of cardiovascular disease in caregivers, of anxiety, depression, and social isolation. So very important in terms of data of caregivers group. Some concerns to mention is that both groups face unrecognized status. When you're a carrier, as also Professor Glenlivan said and Elizabeth, what they discussed at the workshop was how to even call the group. If you call them women with dystrophinopathies or carriers or manifesting carriers and so on. So if you don't know what you'll be called, what your condition's name is, that is stressful and confusing for everyone. But also the status is not recognized in caregivers. So some people say, well, I take care of someone, but they're not really caregivers in such a way that mothers and fathers of Duchenne boys. What we know, and sometimes it seems natural, that caregivers' needs come second or come last. Usually when we have healthy children, mothers say, okay, my child comes first. But then when the child grows up, there is room for mom to focus on herself. But unfortunately, in this situation, when you're taking care of a Duchenne boy or Duchenne girl, your needs don't come first when they grow up. It just gets worse. It is very hard to manage appointments for anyone, for caregivers or carriers. In our country, in the Czech Republic, 50% of caregivers state that they have no replacement. So they don't have anyone to leave their children with or adults with when they need to go to the doctors. We also know there's lack of information and uncertainty on what to do, what effect long-term care has on a person, and what the gene mutation can cause. We don't know if the mutation will manifest sooner or later, if at all, but then it just creates, as I said, uncertainty for the doctor as well as for the person affected. We also know that caregivers usually underplay their symptoms. This applies very much to carriers, that they don't recognize that their condition manifests even because they say, well, I'm tired because I need to take care of my son or of my child. So they just give up and say, well, this is just the burden of care. Now I would like to say something about data that we have available about this group. So first of all, let's start with caregivers. As I mentioned, for Caregivers Act in the US, there was a report that stated that 45% of caregivers have chronic conditions such as cardiovascular disease, cancer, diabetes, or arthritis. To be fair, it usually is 1 in 4 adults who have a chronic condition. So this is twice as much of a risk. 72% of caregivers miss doctor's appointments regularly. 39% report anxiety and 32% report depression. I would also like to mention a paper that was looking into how to deal with children with anxiety, how to treat them, and that stated the results stated that treating the parents of a patient who also are not in a good mental state is just as effective as treating the child themselves. So this is really important. When you're a child and you're not well, it is very important that your parents are doing well and that you're in a stable and good environment. So it is just as important to treat the family as a whole than it is just treating the patient. Now let's look at some numbers of carriers. So 30% of carriers haven't informed their primary doctor about their status. And this tells us something because they don't even feel the need to share this information. In 25%, they don't feel this need because they know that their doctor doesn't know what dystrophy means. 32% of carriers say that they don't need cardio checkup. So they decide for themselves based on what they asked in this study. So 78% said, well, I don't need to go to a cardiologist because I don't have any cardiac symptoms. 68% said, no one told me I should go to a cardiologist, so why should I go? And 50% said, well, I don't even know I'm at risk for cardiomyopathy. Very similar results are of a new survey that Marisol Montolio in Spain did, that says that 47% of carriers do not undergo a medical follow-up, in 88% because they haven't been informed that they need it. So this is a big information for us that we really need to emphasize the need for care in carriers and in caregivers as well. So here are some things to consider. I think that lack of knowledge and how certain health issues manifest is important to consider. Because if you don't know that fatigue or low energy might mean that you are depressed and that can be treated, then you don't feel the need to report it or to say, I need help. Just as well, sometimes it's not recognized that swelling, shortness of breath, fatigue, or low performance are connected with heart disease and can mean that you need to be treated as well. So if you don't feel a problem, you don't feel the need to be checked out. We all know that. And this counts also for dyslipidemia or gynecological prevention. And here are some suggestions. I think it's very important to, first of all, acknowledge the burden of being a carrier and or a caregiver, the need for care. This is also what Professor Quinlivan said in her presentation, is that, first of all, the women want to be considered as a person themselves, not just as a mother of a person with Duchenne. Psychological support and psychosocial support is key. We know that they really fall into social isolation. And as we saw the data, caregivers tend to have more risk of anxiety or depression. So talking to someone and trying to deal with your psychological state is a good way to go. And it is important to mention it. Also, let's remind about importance of regular checkups. This doesn't only apply to carriers or to caregivers, it applies to everyone, but especially in people who do not usually have time to go to the doctors, it is important to remind about it. I think the role of physicians should also be to inform about the risk of heart disease, dyslipidemia, anxiety, depression, and about symptoms that are connected to these diseases. And we all know that more research is needed on this topic, but I think that World Duchenne chose the great way to do it. So just raise awareness and talk about this important issue and try to come up with good care considerations for women. Thank you for attention.
Thank you so much, Carolina, for this really insightful talk, and also about the adherence, which was not really well known. Like 2 years ago, nobody was talking about it. Mothers didn't adhere to normal checks, and now we have many more data. And also thank you to everybody who worked on this, and also the people who did participate in the questionnaire. So we get more and more insight about this adherence problem, and also that they are not offered care where they should have offered care. There's a lot of new initiative ongoing there. And In fact, I think this is the moment to go to the Q&A session. So there will be questions. We do have time for questions. That's really nice. Sometimes that's not so easy, but today we really do have time. So I invite the speakers indeed to open their video and also their microphone if needed. Suzanne, can we see the questions in the V&A?
Definitely. I think we can just start at the beginning. Do you also have them, or do you want me to read them out?
Yeah, I think it's important to state at the beginning that we are not answering to individual questions of individual patients. If there's something which is asked for a specific patient, then it might help the wider audience. That's of course something else, but this is not the place to go for consulting about your own family member. So I would like to start with the question of Dr. Imelda de Groot. Is there any knowledge on carrier mothers of BMD boys, or is there only research on DMD? Who would like to answer this question? We can do it verbally. Yeah, Professor Quinn-Livens.
Yes, no, I think that's a really good question. And in fact, the data that's out there is for both Becker and Duchenne carriers. So the studies, a lot of the cardiac studies are both Becker and Duchenne carriers. And there are case reports of female Becker women who carry the Becker gene presenting with muscle weakness. So it's kind of mixed, but a lot of the studies are just mixed Duchenne and Becker carriers.
Thank you so much. And then there's the next question is like, can physiotherapy help relieve DMD patients' muscle pain or save them from developing contractures? And I think this also should be seen in the context of the females. Yeah. Also for you, Professor Quinn-Livens?
Yes, yeah, no, definitely. So I think it's a bit, I think physiotherapy is very good for preventing contractures. And as Saskia showed quite beautifully, you can see these asymmetric contractures. So trying to prevent those with physiotherapy is very important. In terms of preventing muscle pain and fatigue, that's more difficult. If the pain is secondary to tightness due to contracture, physiotherapy will help, but rather like Becker dystrophy and early Duchenne, if there's muscle cramping, I don't think physiotherapy would help that much, but perhaps doing exercise might help. So being more physically active may actually help with the muscle pain rather than physiotherapy as such. I'd be interested to know what Saskia thinks about it, because that would be my feeling anyway.
Yeah, I agree. And I think also the muscle pain can come to when you're over asking your muscles. So sometimes it's also good to find a balance together with your therapist. What are my boundaries? Don't do too less, but also don't do too much. And maybe sometimes aids can also help. So to support patients. And there is also a physiotherapist who can advise in this.
Thank you. And then also, I think the best is the two of you leave the mic open, because I think both you decide who's answering, or maybe both. And one of the question was like about the use of steroids in females. And I know there was something said more should be studied, but now here's the question is, should we, do you recommend steroids for symptomatic girls with DMD?
So shall I go first, Saskia?
Yes.
And then you can say what you think. I think it depends on the degree of severity of symptoms and the early onset. So if you've got a girl presenting very early with muscle weakness, I would probably consider steroids, because she's more likely to get weaker over time. On the other hand, if you have an older woman with very mild or minimal weakness, you have to balance the side effects against the benefits. So rather like my first slide where I'm showing you a spectrum, I think you have to think of women with dystrophinopathy as sitting on that spectrum. And so the earlier the presentation of weakness, the more likely it's going to be severe. And that those are the patients I would consider starting steroids on.
Thank you. Thank you. And then you maybe want to say something as well, Saskia.
No, just that I totally agree.
Okay.
No additional comments.
No, and then there was for carrier mothers, are there any gynecological problems observed like monthly, is the question from India.
In the young group, we asked specifically, but we did not find those complaints. But I think theoretically, you can imagine that there's also muscle in the uterus or in the, so maybe there is possible, but I think it's also a field that we have to still look for, investigate.
Thank you. Thank you. And there's a question about how do we recognize mild symptoms in older female carriers? Is there any way to determine if fatigue, etc., is truly due to being a carrier, or is it due to simply aging, caregiving, and other chronic condition?
I think that's a really good question. I remember once seeing a lady in her 60s who was diagnosed as a manifesting carrier, which is the term we used to use, because she had muscle weakness. But in fact, when we assessed her, she was thyrotoxic and had overactive thyroid. So it's really important in the older woman to make sure you're not missing something completely different. And if there's an older woman presenting with muscle weakness and you don't find any other cause for that weakness, then I think you can attribute it to the fact that she's carrying the dystrophin gene. But I think you have to always look for other conditions as well.
Yeah, I think there's one question is deleted, which was not yet answered, and that was from Louisine. You asked if mothers who were not carriers also could have cardiac issues, and I think that is what Carolina told us based on the questionnaire you did, right?
Thank you. Yes, I answered it actually, and I just typed the answer. But
oh, sorry.
Yeah, but the data says that they have twice the risk than general population, so it is definitely higher.
And that is based on less exercise, less healthy lifestyle?
I wouldn't say, but just on the burden of care. If you lift up someone and you have really this heavy burden on you, I think it is based mainly on that.
And maybe I can ask the two other clinicians as well. Is that what you've seen also in clinic? I mean, the data are there, but is it also something you see and ask for in the not carrier moms, like how's your cardiac situation, or if they go for checks?
I think it's good to realize that it's not from the, it's not a cardiomyopathy like in dystrophinopathy. So that's important to realize. Maybe there are other causes, but it's not the same mechanism. And having that said, I think it's always important to see how the surrounding of your patient or is doing. And if there are any complaints, then advise them to go to their GP.
Yes, I agree with that.
I think you would say the same, right? Thank you. With this, I think there is, well, I think there's a question about the relation between muscular dystrophy and MS on female carriers, but I'm not sure if somebody thinks that should be discussed. No, I don't think that's a question which is really for here. And then I think we kind of are at the end. We come back at 1/4 so that means 20 minutes break. I mean, this is, you all deserve an applause because this barely ever happens that we have extra time for a break. So we will be back in 20 minutes and then come to the next topic, which is also about women, and that's the cardiology part. Dr. Linda Kripe will present her, she's on holidays, but she was so kind to pre-record her presentation. So she will be the first one after the break. Thank you so much. Well, our next session will be about cardiology in Duchenne in general, but also cardiology for females with dystrophinopathies. And as we already said, the presentation of Professor Linda Kripe is pre-recorded. So we will play that, that recording. After that, Professor Karim Wabi will present about the general cardiac update, and then we will have ample time to answer questions. So Suzanne, maybe you can start.
Thank you very much for the opportunity to talk to you today about the cardiac care for females with dystrophinopathies. I'm Linda Kripe, a professor of pediatrics at Nationwide Children's Hospital in Columbus, Ohio. So why should we be interested in the heart in maternal carriers of Duchenne and Becker muscular dystrophy? It's because maternal carriers are at risk for developing cardiomyopathy. Unfortunately, as we will discover during the course of this conversation, we have questions, and more questions, and very, very few answers. We know that maternal carriers are clearly impacted by the cardiomyopathy. The natural history is unknown and needs to be defined. And I think that this is the number one problem with this in this arena, is that we really don't know who's at risk, how early they're at risk, and what the disease progression is like. We need to determine at what age should we start to be concerned. Should we be concerned at diagnosis, during childhood, or early or mid-adult years? Unfortunately, once the child dies, we lose the family and the mother to follow up. And I think there's tremendous concern that these women are experiencing early cardiac death, and we just don't know the answer to that question. There was one study that was done many years ago looking at death certificates in Scotland that would suggest that that wasn't the case, that they weren't dying of early cardiac death. However, I think that it was done at a time when we weren't as savvy or thinking about it in the way that we would be doing it today. So we really need to revisit this. And can we impact the process with early intervention? How should we treat the cardiomyopathy once it's identified? We'll talk about that a bit in the end of our talk. And all of this highlights the need for genetic testing and carrier identification. I'm going to start with three concepts in understanding Duchenne cardiomyopathy that I think are going to be essential to the rest of the presentation. Concept one is that the Duchenne cardiomyopathy has a unique pathology. It really is a subendocardial process. Here on the slide on the left, you can see that the white tissue in the brown myocardium on the pathology specimen is fibrosis. In patients who have ischemic cardiac disease, it is a subendocardial process, so on the inside of the myocardium. So this is really unique to Duchenne cardiomyopathy and neuromuscular disorders in general. On the right here, you can see an H&E stained slide that also in blue shows you this fibrosis interspersed amongst the myocardial cells. Concept number two that we need to understand is that there's characteristic disease progression in the myocardium. The fibrosis that we just saw starts on the posterior left ventricular wall, moves down the left ventricular wall to the apex of the heart, and then moves up the ventricular septum in end-stage heart failure. It really involves the entire ventricle and then leads to pump failure. So I think it's also important to know that this fibrosis occurs before there's ventricular dysfunction, which also tells us that we need to be looking for the development of this fibrosis in the myocardium, which leads me to the next concept, which imaging allows us to follow this disease process. It allows us to see this fibrosis developing in the myocardium. Historically, it was believed that the cardiomyopathy did not manifest until the late teen or early adult years. And that's because the disease was really characterized when imaging was less sophisticated. It's that concept, if you can't see it, it must not be there. However, contemporary imaging has allowed us to redefine the natural history of Duchenne cardiomyopathy. And as imaging improves, we'll see the disease with new eyes. Two imaging modalities are commonly employed: echocardiography and cardiac MRI. Echocardiography definitely has its limitations. Here you can see an echo that is done in the top three panels are an echocardiogram done in an individual just having an echocardiogram for purposes of evaluating their function. In the bottom, you can see the three panels across horizontally are taken from a patient with Duchenne muscular dystrophy. Because of the body habitus and the water content and the inability to scan them flat on a table, the image quality is very poor in many Duchenne patients, especially in non-ambulatory patients. And these suboptimal images result in poor clinical decision-making and poor clinical trial data. However, cardiac MRI offers significant imaging advantages. There's a lack of radiation exposure. It provides us detailed information about left ventricular and right ventricular function. It allows us to quantitate fibrosis and myocardial strain. The disadvantages are that an IV placement is required. Longer scan times may be needed, and sedation also may be needed. There's also a lack of global availability. So let's now move to talking about female carriers. So what does the prior literature tell us? Well, interestingly, there isn't a lot of prior literature, but what it does tell us is that the disease is there. It is present in the myocardium, but it leaves us still wanting to answer those questions of what is truly the natural history. We'll take a look at some of these studies. One of the first ones was in 2001, which is a retrospective study. They looked at 129 carriers, and they saw echo abnormalities in 5%, had significant evidence of dilated cardiomyopathy with dysfunction, and 5 of those patients had florid symptoms of heart failure. 18% had evidence of myocardial dilation, and 13% had wall motion abnormalities and atrial dilation. They said that 47% in EKG abnormalities, except in their paper they didn't define what those were, and interestingly, only 38% had a completely normal heart, which I think would tell you that 60% of people had some sort of cardiac abnormality in their study, and that was back in 2001. Why this didn't raise larger red flags, I'm not sure. The study was done using echo. It had poorly defined criteria as to what was heart failure and what was echo abnormalities, and so I think it left us wanting, but it definitely suggests that there's a problem here. In a 2015 retrospective study, they looked at 15 genetically confirmed carriers. All, interestingly, had abnormalities on MRI, and they saw many of the things that we had talked about earlier with regards to that fibrosis in the myocardium. They also saw evidence of what they call non-compaction, which is a myocardial thickening with deep trabeculations in the myocardium. So depending on what criteria you use, you can make all carriers manifest or it not be there. So I think what that tells us is that we need to define what is carrier cardiomyopathy, what is the imaging abnormalities that we're going to use to define the need to treat. And that's going to take the entire community to come together in consensus conferences to really sort of think through this in a detailed way. Another 2015 study, 7 of the 22 carriers had evidence of LGE or fibrosis. Of the 7 who were positive, 3 had LV dysfunction. The dysfunction, however, was mild in their study. I think this also depends on the age of the individuals that they're looking at. Obviously, if you're going to be looking at a younger cohort, you're going to see something different than if you're going to be looking at an older cohort. The study that I was involved in was a 2020 prospective study done at Nationwide Children's Hospital by Mei Ling Ma and funded generously by Parent Project Muscular Dystrophy, where we looked at skeletal as well as cardiac muscle evaluations. And we did include treadmill testing. We had 124 subjects with genetic confirmation. We had carrier moms. We had non-carrier moms of Duchenne boys. We had carrier non-moms, and we had also healthy controls. We really wanted to investigate all of the different cohorts. And what we found were that female carriers had a high prevalence of cardiac fibrosis by cardiac MRI. Around 50% of our carriers actually had evidence of fibrosis in the study, which was quite impressive. And we're maybe a little surprised by that. Patients with abnormal function and more fibrosis were older, but LGE was noted by age 30 in the younger patients in our cohort. It would make sense that as you age, you have more dysfunction and more fibrosis. But the fact that we saw it in the younger individuals was concerning to us, because we didn't get into the teenagers. And LGE is definitely in our study paralleled what we saw in the Duchenne boys, that it's definitely seen prior to the development of dysfunction. Interestingly, carrier moms exercise just as well as the controls, and we didn't really see any differences in functional treadmill results. We did, however, note that the onset of ventricular ectopy and recovery, age, and serum CK levels were predictors of fibrosis on cardiac MRI. And the higher your serum CK level was, we definitely associated that with more fibrosis. Oh, there we go. Sorry, I had a little trouble advancing the slide. So here we have a pictorial representation of our results. On the left-hand side, we see ejection fraction. The patients with Duchenne carriers are blue, and the patients in red are controls. The green line here represents an ejection fraction of 55%, which was normal. The average carrier LVEF was around 60%, with a range of 46 to 74%. And 11 of the 74 patients who were carriers in the study had ejection fractions less than 55%. The average control LVEF was 62%, with a range of 50 to 74%. And interestingly, we had two controls who, as a result of enrolling the study, found out that their ejection fractions were less than 55%, with no known explanation. So our study also raised a lot of questions. One of the things we're really interested in is the impact of stress or caregiver stress on the development of fibrosis and left ventricular dysfunction. There's a lot of work now being done in the field of cardiology on the role that stress plays on the myocardium. And I think it could be a significant component of the development of worsening cardiac dysfunction. We also want to know a little bit more closely about the development of fibrosis and the relationship to rhythm abnormalities. And as I mentioned previously, the rate of progression in how it plays into the decline in function. How frequently should cardiac MRI be obtained, and when should treatment be initiated? Should we initiate therapy with the onset of the development of fibrosis or before the decline of function? And then what drugs should we use? Are the answers we seek revealed by the Duchenne and Becker patients? I think that this could be a starting point. And we need to reconcile and harmonize major recommendations from previous care guidelines, three of which are the care considerations published in Lancet Neurology, sponsored by the Center for Disease Control in the United States, the American Heart Association's management of cardiac involvement associated with neuromuscular diseases, and there's also the 2020 AHA guidelines for the management of heart failure. There are likely many more, but we need to really think about all the neuromuscular recommendations for cardiac care in Duchenne and Becker patients, as well as heart failure guidelines throughout the world, and really come together to extrapolate what we know to draft guidance for carriers at risk. With regards to the boys, and I don't think it's necessary to go through this in exquisite detail, and I just listed these things here, we really try to start looking at imaging as early as possible. We get echocardiograms at the time of diagnosis, and once the disease starts to progress, we increase our imaging frequency and really try to use MRI. And I think that is probably what we will need to do with the carrier moms. You know, I think we're going to need to say we will start imaging at age X, and then as we see things, we will image more frequently and modify our recommendations as time goes forward. You know, I put this in here because I think it's important that you know, we emphasize the fact that there's a lot of arguments against cardiac MRI, but I do think that we can manage those negatives, and I think it's going to be essential to manage those negatives, because this is definitely, hopefully you understand that this is definitely the way we're going to need to follow carrier moms in the future, especially when 50% of carrier moms have fibrosis. We are going to need to do cardiac rhythm monitoring in maternal carriers. Atrial and ventricular arrhythmias are common in Duchenne patients. Heart rate variability may also be a marker of cardiac death, and very little data exists regarding the arrhythmias in the Duchenne maternal carrier. So, you know, I think at a minimum, we should get a baseline EKG. We should get an EKG every 2 to 3 years. We should get an annual Holter monitor at least 24 hours, starting at the age of 21, or with evidence of LGE on cardiac MR. Should we place exercise restrictions on these mothers? Should a maternal carrier with LGE run in a marathon? You know, many of the fundraisers associated with this disease are involved in 5K runs or half marathons or marathons. And should we be letting our maternal carriers be training and running for these events? Laboratory monitoring. There's also very little guidance with regards to laboratory monitoring. You know, we monitor the boys with BNPs, which is a marker of cardiac dysfunction. Troponin elevations are difficult to interpret. And there are clearly baseline troponin elevations with intermittent spikes. And what these mean, I think it's very difficult to know. So our recommendations for the DMD drug patient on drug therapy is that they have an annual metabolic panel and monitor renal function, maybe an annual troponin or BNP. And with the onset of dysfunction, we really need to ramp up those recommendations and think about how we're going to monitor people more effectively. So let's now talk about some therapies. And unfortunately, I'm not going to be able to provide you with what I think everybody's looking for is what should we be doing? You know, treatment with ACE inhibitors and ARBs are commonplace now in treatment of Duchenne and their first line therapy. We typically start them around the age of 10 or when there's the onset of dysfunction. And you know, they have been shown to slow disease progression. We need to obviously monitor renal function and electrolytes. You know, I think this is an easy place to start with the Duchenne carriers. Should they be treated early, even before fibrosis develops, or should we wait until we see something on cardiac MRI? You know, I think that has yet to be seen. We should also treat with beta blockers. A beta blocker is recommended for use in Duchenne patients as second-line therapy. Duchenne patients commonly manifest tachycardia prior to the onset of ventricular dysfunction, which may be of benefit in this subgroup of patients. And you know, I think it's a great drug. It's easy to use. We have an enormous amount of experience. And whether it'll be able to help the carrier population, I think we're just going to need to know over time. Mineralocorticoid receptor antagonists are also now relatively commonplace in this patient population. And specifically, we are using spironolactone and eplerenone, probably more eplerenone at the moment than spironolactone. And so I think it's really reasonable to consider the initiation of these drugs in the maternal carrier, especially when we're seeing the onset of fibrosis, because they do have a anti-fibrotic property to them. And then, you know, really, this is an amazing time in the field of heart failure. There there is an enormous number of drugs, and some of them are listed here, coming online with regards to the treatment of heart failure. And whether these will benefit the Duchenne boys or whether they'll benefit the maternal carriers has yet to be seen. So in summary, as I said at the beginning, there are now, unfortunately, many more questions than there are answers. But, you know, I mean, I guess that's where we need to start, by understanding the natural history of the carrier cardiomyopathy. You know, I think some of the studies that have been done to date have given us an initial footprint, but I think the way we're going to need to do this is come together as a world to combine our natural history data to get the numbers that we need to really understand what the problem is. And what is the morbidity and mortality as a result of the problem? I mean, clearly it's impacting the myocardium, and clearly it's impacting the myocardium in some individuals significantly. But how big of a problem is it? And, you know, is it more that, you know, these hearts are manifesting fibrosis, but it really never manifests significant dysfunction in most people? Or do we really need to start blowing the whistle that it's more of something that we need to track earlier? And who's at risk, and how early are they affected? And I think it's meetings like this that really highlight the need to develop international treatment guidelines. You know, we need to come together. We need to hold hands together as a world and use the information that we get and share the information that we get, because I think together we will be stronger. I definitely appreciate the opportunity to speak today, because collaborative efforts such as these are a refreshing and welcome start. So once again, thank you for the opportunity, and I hope the rest of the conference goes as anticipated extremely well.
Then, although I say it to the screen, but I already thanked her online before. Thank you so much, Professor Linda Kripe, for this presentation. And then I would love to introduce the next speaker, which is Professor Karim Wabi, who's already for many years always available or willing to present to clinicians to teach the world how to care best for Duchenne and Becker patients. And the floor is yours. Thank you so much again that you're here today.
Thank you very much, Elizabeth. I hope you can hear me well.
Yeah, we can.
So I'm very grateful for this invitation. It's a great pleasure for me to give this talk on Duchenne cardiomyopathy. And it's really fantastic to see so many people from so many countries connected. And so I will present today the most important and the most novel aspects regarding cardiac management in DMD, on both diagnostic and therapeutic aspects. If you want more information on cardiac management in DMD, we have a lot of excellent documents available, and you can go through these documents, and you will see that many aspects regarding patient management are really consensual, such as the use of ACE inhibitors or glucocorticoids. But some others are less consensual, more controversial, and I'll try to discuss that with you today. So first of all, Linda Kripe mentioned that in her talk, there's a specific cardiomyopathy pattern in patients with DMD and dystrophinopathies in general, which is mainly characterized by an involvement of the cardiac muscle, with the myocardial tissue progressively replaced by fibrosis, initially mainly in the inferolateral wall, and then this fibrosis gets widespread, and the development of fibrosis is associated secondarily with an abnormal contractility, mainly of the left ventricle, and in some patients, the development of dilated cardiomyopathy. And later in the course of the disease, some patients may develop, unfortunately, heart failure, which still represents one of the most common causes of death in patients with DMD. Electrical abnormalities can be observed too, but they are I think, far less frequent than myocardial abnormalities. And unfortunately, some patients die suddenly due to ventricular tachyarrhythmias, but it's far less common than terminal heart failure. We have several tools available for the diagnosis of DMD cardiomyopathy. Very simple one is the ECG, which generally shows Q waves in the inferolateral walls and full air waves in the right precordial walls, which are more or less correlated to the development of fibrosis at the myocardial level. And the echo, I think Linda nicely presented what we can see on the echo. The echocardiogram has the advantage to be easily done, to be accessible, to be non-invasive, and to have a quite simple assessment of the cardiac contractility. And it's a first-line examination for the diagnosis of dilated cardiomyopathy. Obviously, cardiac MRI, which has been used more recently in patients with DMD, is more sensitive for the diagnosis of contractility abnormalities. It's also had the potential to identify fibrosis at the myocardial level, which cannot be seen with the echo. But there are also limitations regarding the accessibility and the feasibility, particularly in young patients, because before the age of 7 years, you need to have a sedation in majority of cases to have proper MRI done. And older patients, particularly when they have respiratory failure or muscle retractions, many patients do not tolerate the fact of lying on their back for 20 or 30 minutes. So there are also feasibility issues with MRI. Blood biomarkers can be useful, particularly heart failure biomarkers, such as the BNP and the NT-proBNP, who are probably less accurate for the diagnosis and for the prognosis than in the general population, particularly in patients who have lost ambulation. But I think it's a useful tool in combination with the echo for the assessment of myocardial disease. Holter ECG can be useful sometimes for the diagnosis of paroxysmal arrhythmias. We know from studies which have been conducted prior to the usage of other prophylactic treatments I will present further, various studies have shown that the prevalence of cardiac involvement, and particularly of dilated cardiomyopathy, which is defined by an impairment of the global contractility of the left ventricle, well, that the prevalence of DCM increases progressively after the age of 10 years. And without prophylactic treatment, a majority of patients develop DCM when they are adults. We know from studies with the MRI that when you look carefully at what happens at the myocardial level, even prior to the development of LV systolic dysfunction, that you can identify, on one hand, fibrosis quite often before the age of 10 years, not in all patients, but it's not that uncommon. But also contractility abnormalities using assessments such as myocardial strain and particularly circumferential strain, which can be impaired quite early in the course of the disease. And myocardial strain is probably a good predictor of the further decline of the ejection fraction. So for the diagnosis, how can we use those examinations? I think there's a global consensus to say that at diagnosis, all patients need to have an ECG and an echo. Probably the first, an MRI is very important quite early after the diagnosis, but it's probably reasonable to offer an MRI after the age of 7 years when it can be easily done, because before that, the MRI would not necessarily have implications in terms of treatment, but after the age of 7 years, you can discuss an earlier usage of some specific therapies. Other ECG could be used probably mainly in patients who have significant cardiac dysfunction, because otherwise it's generally normal and it doesn't change how you manage patient treatments. And then during follow-up, you need to repeat cardiac assessments at least on a yearly basis, because it's very important to diagnose early changes in the expression of the disease at the myocardial level. Some patients have a very progressive decline of cardiac function, but some others, for some reason, have a rapid decline. And from 1 year to another, you can see sometimes major changes. And it is very important to identify those patients early and to offer them a rapid increase of all the therapeutic approaches you can offer to stop the disease or to limit the progression of the disease. One quite controversial question is how often cardiac MRI should be repeated. In some countries, particularly in some centers in the US, cardiac MRI is done almost every year. Some centers use cardiac MRI far less frequently. I think it's reasonable, once you have a first MRI around the age of year, to repeat around the age of 7 years, to repeat this examination a few years later, perhaps at least 3 to 5 years later, because at that age, the identification of fibrosis can have a major impact on the choices you can make to treat patients. So I think it's quite reasonable, and many centers use this approach. And then you can repeat a MRI when it's feasible, perhaps every 3 to 5 years. I think it's a good compromise between what most experts on DMD cardiomyopathy recommend. I will move on now to the treatment, to the therapeutic aspects. I think it's very important to have in mind the difference between all the preventive prophylactic treatments that need to be used, even in patients who have a normal cardiac function, which are different to all the curative treatments you can use once you identify an overt cardiac involvement and dilated cardiomyopathy. So a number of prophylactic treatments have proven beneficial to delay the development of dilated cardiomyopathy and improve long-term prognosis. And it's very important to use them systematically. The first two treatments who have proven beneficial are ACE inhibitors and glucocorticoids. For ACE inhibitors, we have a randomized trial has been conducted by our group and overseen by of Duboc, who showed that when you start a treatment with an ACE inhibitor, which is the most commonly used treatment for heart failure in the general population, that when you treat patients prophylactically around the age of 10 years, when the cardiac function is still preserved, that treatment is associated with a reduced risk for patients to develop dilated cardiomyopathy at 5 years, and an improved overall survival, mainly because patients develop less frequently severe heart failure at 10 years. So following the publication of this study, ACE inhibitors have been used worldwide, at least in expert centers. And I think the indication to start an ACE inhibitor before the age of 10 years is now really consensual. More recently, we have shown, based on the analysis of a French registry with more than 700 patients, that in a real-life setting, the usage in a large number of patients of ACE inhibitors prophylactically was associated with a significant risk for patients to develop terminal heart failure. The benefit was really huge. And I think this study really confirmed the data we had from the single randomized trial that had been published more than 15 years ago. We have a number of studies, mainly only observational studies, but with consistent results showing that the usage of glucocorticoids in patients with DMD is associated with a reduced risk for patients for diabetic cardiomyopathy and a reduced risk for terminal heart failure. So obviously there's benefits for the usage of those treatments, but sometimes it's quite difficult to make decisions in patients who are older, who have lost ambulation, whether glucocorticoids should be continued or not, but probably the benefit of glucocorticoids at the cardiac level would represent a supplemental reason, if the treatment is globally well tolerated, to continue in patients, even if they do not have overt myocardial dysfunction. So I mentioned ACE inhibitors and glucocorticoids, and we are currently in this situation where we have other drugs who are commonly used for the treatment of heart failure in the general population, who have potentially a place in indication in patients with DMD. The first drug is beta blockers. Linda Cried mentioned the potential benefit to use beta blockers. We have some observational retrospective study showing that beta blockers may be associated with a reduced risk for patients to develop DCM, but there are not so many studies and unfortunately few patients included in those analyses. We have one randomized trial conducted in the UK with unfortunately negative results, but there was obviously a lack of statistical power because our colleagues could not include a sufficient number of patients. And we have a randomized trial conducted in France, and we are currently in the process of analyzing our data. But I think that globally, there's a consensus to recommend the initiation of beta blockers in patients who have early signs of cardiac dysfunction with an ejection fraction of below 50%. And many patients complained of palpitations due to sinus node tachycardia. And I think in this situation, I tend to use beta blockers to reduce heart rate. Many patients feel more comfortable with the treatment. And I think it can represent a good indication for patients with DMD. Another treatment, which is commonly used for the treatment of heart failure in the general population, is eplerenone. This is a mineralocorticoid receptor antagonist. And we have a single study published in Lancet Neurology a few years ago, showing that in patients with DMD, pediatric patients with a preserved cardiac function who had evidence of fibrosis on MRI, then the usage of eplerenone on top of ACE inhibitors was associated with a reduced risk for patients to have decline of contractility parameters, myocardial strain, and perhaps even ejection fraction. So I think it's reasonable to initiate this treatment in patients who have fibrosis on MRI, even if the cardiac function is preserved. And finally, it's very important in patients who have dilated cardiomyopathy with an significantly impaired myocardial contractility to implement majority of treatments we have available for the treatment of heart failure in the general population. And it's sometimes difficult to put patients on several medications, but it's probably beneficial, and it's probably important to initiate treatments early and at significant doses in order to make sure that your treatments will have a significant effect to limit the progression of disease. The earlier, the better. And sometimes you're in the situation where, unfortunately, patients develop severe systolic dysfunction, particularly with an ejection fraction of below 35%, or sometimes severe and terminal heart failure. In patients with severe LV dysfunction, there's theoretically an indication to implant an ICD in patients who have dilated cardiomyopathy of any cause or ischemic heart disease. but probably the ratio between the benefit and the risk of the implantation of ICDs in patients with Duchenne is probably not that favorable, and probably ICDs should be implanted in selected patients have evidence of ventricular tachycardia, but otherwise systematic implantations are probably not beneficial, because on one hand you have risk for ventricular tachyarrhythmia, which is probably lower than in some other dilated cardiomyopathies. And on the other hand, the morbidity of the implantation is probably higher due to chest deformations, respiratory failure. And in this situation where patients unfortunately develop terminal heart failure, well, the situations are really difficult to handle. Unfortunately, you cannot offer patients cardiac transplantation because when the cardiac function is severely impaired, almost all patients have at that stage a respiratory failure, and it's not possible to have a major cardiac surgery in patients who with respiratory failure. But sometimes, in some cases, in selected patients, you have the possibility to offer patients the implantation of an LVAD, a left ventricular assist device, which is a cardiac pump, which is implanted surgically at the top of the heart. And some patients can live quite normal life with such devices, but you need to make sure that patients have a family with them to help them monitor all the aspects that have to be monitored in the carriers of such devices. Have to make sure that patient has life project, quality of life, in order to make sure that the implantation of such device makes sense. And you have also to be really careful at concomitant development of respiratory failure, because sometimes the implantation of the device can be challenging in patients with severe respiratory failure. So it's possibly an option, and sometimes a good option, in highly selected patients. And we have implanted 10 patients so far with very good results. And this will be my last slide. I think it's very important to keep in mind that we have now a large number of innovative therapies that will be usable in the next years: gene therapy, exon skipping therapy, gene editing. And the good news is that most of those therapeutic approaches also have the potential to treat the cardiac muscle as well. We may have in the future, particularly in patients treated early in the course of the disease, an impact of those therapies for the prevention of the development of dilated cardiomyopathy and the improvement of long-term cardiovascular outcomes. Thank you for your attention.
Sorry. Thank you so much for this really wonderful talk. And I see there are several questions for you, if you are okay to answer them. One question, which was about gene therapy and the risk, we referred that question to a workshop which will be given about gene therapy. If you still feel like you want to say something for the cardiac risk about that, then you're welcome to answer it.
Well, we have preliminary preclinical and unfortunately clinical data suggesting that some therapeutic approaches may be associated with cardiovascular events. The most common ones seem to be myocarditis. There's probably in some patients a kind of inflammatory response at the myocardial level. There are a few really dramatic cases of patients who unfortunately died following the occurrence of such complications. It's not completely clear at the moment what are the underlying mechanisms. I think we need to be very careful in the future clinical trials and in the ongoing clinical trials to monitor cardiac function in order to identify quite early these kind of adverse events. And probably if we know early that there's an inflammatory response at the myocardial level, we may be able to treat patients with, immunosuppressive therapies in order to avoid the development of severe cardiac complications. So I think it's something very important, and we need to be very careful on those aspects in the future years.
Thank you so much. Thanks so much. As I said, there will be soon, or upcoming, is a webinar about gene therapy for this audience. Then another question is: can early eutrophin upregulation help in cardiac preservation? Is eutrophin better than dystrophin for the heart?
Excuse me, Elizabeth, I couldn't.
Yeah, the question was: can early eutrophin upregulation help in cardiac preservation? So is eutrophin better than dystrophin for the heart? That was the question.
I think we do not really have an answer to that question. We have obviously only preclinical data on those aspects, and it's quite difficult to determine whether there's a significant difference between one approach or another in order to, in the future, to treat patients. So I think it's still an open question.
Thank you so much. Thank you. And then there was a question about, I don't know if you see the questions, but there's a question about if vamorolone is approved, will patients taking eplerenone as a cardiac antifibrotic be titrated? Would it double up with a comparator cause potassium or BP problems, given this was published in 2019 by Spurney, Hoffman et al. They said vamorolone, eplerenone, and spironolactone inhibit MR activity in a dose-depending manner. So the amount of MR inhibition shown by vamorolone closely resembles that of eplerenone in the in vitro system.
Okay, so I have the question, yeah.
Yeah, I thought you better read it.
Thank
and
you.
give it to me.
I'm sorry.
No, because it's a long question. No, that's why I asked.
I think we have only indirect information regarding the potential, cumulative or antagonist effects between one drug and another. I think we have evidence in a clinical study of obviously the benefit associated with MRAs. We know from studies in the general population that this treatment is highly beneficial for heart failure. We have a large number of preclinical studies showing that it's beneficial in DMD, particularly in mouse models. And we have a preliminary study showing that possibly it's really beneficial even in patients. So I think obviously we should use eplerenone as the first-line treatment to as an antifibrotic therapy in patients with DMD. So if the question is whether vamorolone in combination with eplerenone if the combination of vamorolone with eplerenone or spironolactone, which is quite similar to eplerenone, results in a different MR activity, is quite indirect. And I think in the future, we will have probably larger indications for eplerenone, and we could have the potential to use in combination with vamorolone.
Thank you so much. Thank you. And then the last, I think short question is it possible for the cardiac decline to take place before loss of ambulation?
Fortunately, yes, it's quite uncommon, but it happens that patients who are still ambulant develop significant dilated cardiomyopathy. I think terminal heart failure before loss of ambulation is very, very uncommon, but sometimes it happens, particularly for some reason. We don't know exactly why. Some patients have a very rapid decline at some point of the cardiac function, which may possibly relate it sometimes to myocardial inflammation secondary to viral infections. And in that case, we have seen some patients developing quite early terminal heart failure. But currently, when patients are treated prophylactically with ACE inhibitors and glucocorticoids, it's very, very uncommon.
Thank you so much. Really, thank you. And for the people, not all questions could be answered, but I think the majority is. And then I would like to thank you taking all these questions as well about cardiology, and also thank you so much for your talk. Thank you again.
Thank you very much.
Thank you. Thank you. And then the next session, with this, the session on cardiology is closed, but then the next session is about endocrinology in DMD. That's also a subject which is discussed a lot over the last years. And the first speaker here is Dr. Jared Wong, the pediatric endocrinologist and senior research fellow at the Royal Hospital for Sick Children in Glasgow. And the talk will be about revisiting the approach to osteoporosis management in DMD. The floor is yours. You are also a very, very loyal speaker to educate the rest of the world. Thank you so much.
Thanks, Elizabeth. Elizabeth, are my slides up?
Yeah, your slides are up. Yeah.
Great.
Perfect.
Okay. Thanks very much for World Duchenne Organization for inviting me to talk about this topic, about the approach to osteoporosis management detailed in the 2018 International Standards of Care, but also looking forward into how this might need to be revised in light of recent understanding and experience. These are my disclosure. The only one that is of relevance is highlighted with an asterisk, as I will be discussing bisphosphonate, but obviously this is as part of the current recommendations, but with some thoughts for the future. So I was going to give you a talk, but I realized that it's towards the end of a long session and people are getting tired. And rather than giving you a talk, I thought I'll take you through the story of a boy who's called Lewis, who seems to be quite a popular name for Scottish boys these days. Lewis was born healthy, but around the age of 2 years of age, there were some muscle issues, some tendency to fall, which was alerted to attention to different people. And after a long few years of referrals and reviews, he was diagnosed with Duchenne muscular dystrophy at the age of 4. This obviously was quite devastating for the family initially, but then they found out that actually there can be treatment that could perhaps slow down the course of the disease progression. And steroids was discussed by Lewis's neuromuscular clinician, and this was started at the age of 5. He was started on daily steroids at the age of 5. At the age of 8, probably about 3 years after starting daily steroids, Lewis developed really bad back pain. The family were aware that, there may be some issues with weaker bones or and the tendency to fracture, but it took a little while for them to actually figure out what was wrong, because at first they thought it was just the muscle ache. They thought it was just basically due to his position, but it really did take a little while, and he attended the emergency department. And finally, somebody did a spine X-ray, or a lateral thoracolumbar spine X-ray, which is what is now recommended. But what we found out in the emergency department was Lewis actually had multiple vertebral fractures, which is very common in boys with DMD, particularly those on steroids. And just to take you through some of the images on the slide, you can see that this is a lateral image of the normal spine, where all these vertebrae are nicely shaped rectangle, but this on this side, where you can see that there are multiple vertebral fractures, and in fact some of them are very severe. And I'll come and talk to you about the grading of fractures and how this relates to how we should actually be managing such patients as according to standards of care. Lewis's family obviously were very worried, because they thought, he's in such a lot of pain, and what does this all mean? So let's just detour a little bit from Lewis's story to talk about osteoporosis in boys with DMD. We do know some of it from clinical data, some of it from preclinical data in animal models of DMD, that there is already some bone phenotype in boys with DMD prior to the onset of steroids, prior to use of steroids. And that's not surprising, because muscle activation, physical activity is very important to help bone development during childhood. We do know the importance of steroids as part of the standards of care in terms of prolonging ambulation and all these health benefits for sure, but steroids does have an impact on bones and does lead to poorer bone development via numerous mechanisms, which I'll describe in the next slide. We also now know, based on a lot of studies from various different sites from our work from the Scottish cohort and also the North Star database, that actually with follow-up, potentially 50 up to 70% of boys with DMD will suffer a fracture, both long bone, but also osteoporotic vertebral fractures. We do know that fractures seems to be less common in those on intermittent regimen, better study in those on 10-10. We don't have that much information on the other types of intermittent regimen, but these are fractures are still present, including vertebral fractures. And based on some much more recently presented data from recently completed clinical trials, we now know that after 3 years of steroids, particularly on daily steroids, approximately 30% of boys with DMD will have signs of vertebral fractures. And the reason boys with DMD have weak bones is for a few reasons. And again, I'll go through these reasons again. So as I mentioned, muscle development, physical activity, particularly weight bearing and high intensity physical activity is very important to help bone development, particularly improving the size and the dimension of the bones throughout childhood. We know, of course, that's impaired in boys with DMD, and muscle function will weaken with time. We also know that during childhood, as boys and girls grow, and at the time of adolescence, as boys and girls go through puberty, bones become stronger in that the size of the bones become thicker. But we do also know, of course, with the use of steroids, like prednisolone or deflazacort, growth and puberty is impaired. And in fact, quite often on boys on daily steroids, after 4 to 5 years, there almost is no growth at all. And this is also another factor which leads to the poorer bone development over time. Steroids themselves also have a direct impact, negative impact on bones. And of course, we know that some boys with DMD are not out in the sun as much as boys without DMD, and vitamin D deficiency can be quite common, and this certainly compounds the underlying bone phenotype in boys with DMD. And therefore, all these factors, poor muscle function, poor growth, and delayed puberty or lack of puberty, which Claire will talk in the next steps, the direct impact of steroids themselves, and also some nutritional issues like vitamin D deficiency and maybe poorer calcium intake, leads to bones which are lower in density. They don't grow as well. And of course, these bones are also smaller and thinner. And just on this slide, again, particularly with the long bone fractures, it's not just because of the low or poor bone density that these boys fracture, but if you've got a thick log like this, and this is a picture from a park that's just like 10 minutes walk from me, you can see this is a big log. If you want to try to snap that big log or break that big log, it's quite difficult. But if you've got a thin twig, it's very, very easy to snap. Even a young child could snap that. So you can imagine how bone size itself also leads to one of the reasons why boys with DMD fracture. So certainly that may explain the long bone fracture, whereas the low bone density is probably the predominant driver of why the spine fractures in boys with DMD. So with vertebral fractures or spine fracture, these can present with very severe bad back pain, like what Lewis had. You sometimes also see intermittent low-grade back pain, which is not as classic, acute, and severe. Bearing in mind, asking about back pain in boys with DMD can sometimes be challenging, because we do know some boys with DMD have a degree of neurocognitive issues like autism and some with learning difficulties. So sometimes it can be quite difficult to ascertain back pain. In older boys with DMD, we also know that some can have back pain as due to postural muscular issue. But we also know that vertebral fractures can be present, including quite severe or advanced stages of vertebral fractures without back pain. But with the presence of vertebral fracture, this is a very good sign that the bones are extremely fragile, and certainly is a diagnostic criteria of osteoporosis in growing children. Once identified, vertebral fractures, especially in a young person with an underlying condition where we cannot improve the underlying condition, meaning we can't improve the muscles, we can't remove steroids or the insult to the skeleton, vertebral fractures will progress without treatment. And there is something that I think will need to be reviewed in terms of how we introduce therapies in these children. And as part of the 2018 International Standards of Care, monitoring to identify vertebral fractures early is now part of standards of care. So these should be familiar to most of you, but just to go through those, it has been recommended that imaging of the back to identify vertebral fractures 1 to 2 years on steroids and 2 to 3 years or not on steroids is recommended. In the UK, we thought that it was just easier to standardize it to annual imaging so that it's not forgotten. And all boys should have a DEXA scan to measure bone density once a year. And if there's some decline in bone density, particularly if you're not imaging the back as frequently as annually, that should trigger an annual assessment of the spine for vertebral fractures, and clearly addressing vitamin D in terms of supplementation and checking for blood tests is also very useful. Lewis's doctor reviewed him in the emergency department, and after discussing with another specialist, Lewis was actually started on a bone protective medicine called bisphosphonate or zoledronate, which I think a lot of you might be familiar with. So the threshold for treatment in accordance with the international standards of care recommends that bisphosphonate should be initiated with long bone fracture with minimal injury, any vertebral fracture with back pain, but also vertebral fracture without back pain if it's moderate in category or severe in category. What are bisphosphonate? Bisphosphonate are drugs which targets the osteoclast, which leads to increased bone breakdown. So we don't actually have a medicine that actually can improve bone development at this stage. What does bisphosphonate do? It improves back pain where there is back pain, improves bone density, stabilize existing fracture, and might prevent the development of new severe vertebral fractures. There might be some impact on prevention of long bone fracture. And zoledronate commonly is used in this setting, although pomegranate can also be used in some centers. And we do have now one randomized controlled trial conducted in Australia and New Zealand, which compared intravenous bisphosphonate and zoledronate compared with a no treatment arm. And we can see that over 2 years of treatment that spine bone density is about 1 standard deviation higher in those who are treated with bisphosphonate with zoledronate compared to those who are not treated. Lewis became unwell a day after his bisphosphonate infusion and vomited and had to be brought to hospital. And Lewis eventually received an injection of steroid and was put on a steroid drip and fluids for over 24 hours, although it took a while for his mum to tell the doctors in the hospital about the fact that he has adrenal insufficiency. And it is important to realize that a common first dose side effect reaction of the intravenous bisphosphonate is an acute reaction, very similar, I guess, to the COVID vaccine type reaction with fever, sometimes vomiting, tummy upsets, and also headaches and fever. And in this instance, extra steroids is needed. And if the child or young person vomits and can't keep steroids down, intravenous or injection of steroids is needed. Obviously, great protocol developed by PPMD, the PJ Nikolov steroid protocol is developed and can be followed. And in the UK via DMDK UK, and also the British Society of Pediatric Endocrinology and Diabetes, we also have UK national guidance on that matter, but certainly, follow whatever existing guidance there is or the PPMD, PJ Nikolov protocol. This is really just to give you an idea of how the pathways of standards of care have changed. In 2010, there was not very much recommendation of osteoporosis therapy. And in 2018, there was initiation of bisphosphonate with spine monitoring. And you can see this probably relates to the fact that at the time of the development of the 2018 standards of care, there was really very, very little studies in bisphosphonate. These are different types of bisphosphonate. By 2018, there was a little bit more information, but these studies were all very small. But since then, there have been a lot more studies, and including, like I say, a randomized controlled trial specifically in boys with Duchenne muscular dystrophy. So in Glasgow, how have we moved on in terms of managing these boys? And we started spine monitoring in 2016, but starting bisphosphonate, but waiting till some back pain. And in 2018, we started moving into the international standards of care, but actually quite quickly realized that maybe we should be changing how we manage these boys by initiating bisphosphonate maybe a little bit earlier, but of course, COVID hit. Since 2021, what we have now instituted in Glasgow is that bisphosphonate is introduced once there are any mild vertebral fracture. And I think there is a case in this population to consider even earlier treatment, but that requires a little bit of time. And the reason we've changed that, that thought of not just waiting for moderate or severe vertebral fracture is highlighted by, this is one of my patients, and we have a series of these patients that we have seen over time and which we're hoping to report. So this is an 11-year-old boy on the left. It was the same boy. He's ambulant. He's on daily prednisolone, had no back pain. And you can see that there are some mild changes of mild vertebral fractures. And in the span of about a year, without any falls, without any further injury, you can see that some of these vertebrae have actually completely collapsed and become very severe. So this is what we call the vertebral fracture cascade. And based on this, we believe that mild vertebral fractures should be treated with bisphosphonate, particularly those who are on daily steroids. So just to revise some of the current 2018 standards of care, that regular and routine spine monitoring with lateral thoracolumbar spine radiographs or lateral DEXA image, if you've got DEXAs, which allow you to do that, should be part of standards of care for osteoporosis management. And following first fracture, referral for consideration of bisphosphonate therapy should be in place, but intravenous bisphosphonate is associated with first dose reaction, and therefore steroid sick day dosing should be discussed and in place. But on top of all these things, one of the important things, particularly in adolescents, management of delayed puberty is very important, and Claire will discuss that next. But what I'm asking and what I'm proposing is, in fact, actually these guidance should be reconsidered. And actually, if you find mild vertebral fractures, even if asymptomatic, particularly on daily steroids, that there is actually a case to consider treatment with bisphosphonate. But moving forward, given that we know that the vertebral fracture and also long bone fracture burden is high, and that these will progress in time, the consideration of osteoporosis therapy prior to first fracture should be reviewed and considered as part of standards of care. And there are groups of people in the international sphere are looking into this topic on how we do it, or which are the patients that we should actually prioritize. But research into risk factors that could identify boys with the highest risk of developing fractures may allow us to then target treatment in those rather than just giving all boys with bisphosphonate. And collectively, the clinical, the academic, and the patient community should work together to develop revisions to these clinical pathways that are also patient-centric. But also think of some sort of way of actually gathering the evidence as we change the standards of care, which I think is very important, because conducting randomized controlled trials of clinical management of DMD, not just of the primary management of the muscle condition itself, is extremely challenging, if not very difficult. So finally, I just want to thank everyone, the World Duchenne Organization, lots of people who are listed here, and I'm sure there are many other people, and also some of the people who have supported and also funded some of my research and also educational opportunities. So thank you very much, and I'm sure we can address some questions later on.
Dr. Wong, thank you so much for your talk about this field, which is really now over the last year getting more and more attention. And I would say we are super happy that this is getting more attention. And you, in fact, already introduced the next speaker, because you already mentioned that Dr. Claire Wood would speak about puberty in Duchenne. I see her video on already. And the subject of this talk is, as we said, the puberty in Duchenne, but also she's a pediatric endocrinologist at the University of Newcastle. And I would say the floor is yours. And later, after the third talk, we can do the question and answers if you all agree. So, Dr. Wood, go ahead.
Thanks. Yeah, I'm having problems sharing my screen actually, so I might just have to log out and log in again for 2 seconds.
Or Suzanne, yeah, or Suzanne can do it for you, and you just say next slide.
Okay, yeah, that's absolutely fine. Yeah, it might be
Yeah,
easier.
slides
Here's
ready.
everything
That's-
ready. Yeah.
There we go.
Thanks, that's lovely. So yeah, next slide. So yeah, as Jared's already said, you know, puberty is important for lots of different reasons in Duchenne, you know, bone health as well, but it's something that over the last few years we've become increasingly aware is a particular problem in this population, and certainly in those who are treated with daily steroids, pubertal delay is almost universal. Not only is it a problem in terms of, you know, psychological impact for these young men who ultimately just want to be like their peers, but it's critical in terms of the timing for bone health. And we know, as Jared just said earlier, that up to half of the boys who do fall lose ambulation after they fracture. And this tends to happen around the age of 13 anyway, which is the peak time when these, oh, sorry, somebody's saying there's no slides actually.
Suzanne,
Oh, that's odd.
next slide.
Does it work now?
I see your slides.
You can see them, can you? Somebody just, it popped up in the chat saying that there was no slide. I just want to check. Can anyone else see them?
We do see the slides, unfortunately. I think that's an issue on their side.
Okay, super. That's fine. I'll carry on then. Sorry. Yeah, so I would say up to half of these boys lose ambulation after they do fracture. And in part, that's relating to the pictures that Jared showed, you know, of those logs. And what we're really hoping to do with the implication with giving testosterone is to make the bones not only wider and longer, but also intrinsically stronger. And you can see here the graph on the bottom left of the screen that bone mass accrual happens during childhood, but then you can see this exponential growth during puberty. And the top blue line is of a male's bone mass. And hopefully you can see by the ages of sort of 10 to 20, their bone mass doubles. And obviously this reaches a peak around the ages of sort of late 20 to 30. But the huge increase in bone mass happens during puberty. And that's why we're so concerned really in Duchenne with ensuring that puberty happens at an appropriate time. Can you click again? There's another part of the slide, I think. Yes, sorry. And again. Yeah, and this is just an example of DEXA scoring. And hopefully you can see here that there's a gradual decrease in the bone density for age. But then there's this huge drop off that happens between the ages of 11 and 14. And that's because this data has been compared with a normal healthy boy who's gone through puberty. And so hopefully you can see there that compared to the population, you know, not going through puberty has a huge impact on your bone health. Next slide, please. So we know that there are lots of benefits to testosterone. As I've just talked about, you know, bone health probably is arguably the main factor here. It also increases height velocity. And as Jared said, you know, often you don't see any growth at all in the years sort of around puberty. The normal healthy male gains around a sort of ruler's worth, about 30 centimeters during puberty. It obviously, you know, leads to virilization, development of male sex characteristics, you know, the sort of the typical facial appearance, the increased muscle bulk, the facial hair. It also, which we don't think about quite as much, but it increases red cell production, which obviously, given that red cells carry your oxygen around your body, this is also of critical importance in this population as well. And I'm going to talk about some work in a second, but testosterone is also important to increase lean muscle mass and strength as well. So next slide, please. So we had a look in Newcastle, it was over 10 years ago now, at the boys that we treated or we just started to treat for delayed puberty. And we found that there was a variation in the regimen that we were using, the doses, the type of testosterone that we were giving, the length of time that we were giving it for. And so what we wanted to do was set about and actually ask the boys themselves to, you know, tell us what they liked and what they didn't like about testosterone to induce puberty. And so to do that, we did it in a controlled way. So we took 15 boys, all who obviously had Duchenne, who were prepubertal between 12 and 17, and gave them a standardized regimen of testosterone. So this was an intramuscular injection every 4 weeks for 2 years. And we gradually increased the dose so that by the end of the 2 years, they were on an adult dose of this. And what we did was, because it was a controlled study, we reviewed these boys every 6 months during the regimen and then reviewed them again 6 months after they stopped treatment. Next slide, please. And the main outcome measure that we used in the study, all the secondary measures don't really matter just now for this, but we wanted to actually understand the boys' experiences themselves. So we wanted to use a patient-reported outcome. So we used the treatment satisfaction questionnaire for medication. And obviously it's important for us to know whether they did actually go through puberty. And in particular, we also wanted to look at the muscle component and look at the effect of testosterone on muscle. So we looked at that in detail by doing MRI of the upper and the lower limbs as well. So next slide, please. So these are just some of the basic characteristics of the 15 boys. So 3 of the boys were non-ambulant at the beginning of the study, and 12 of them were still able to walk. And you can see the average age at the beginning of the study was 13.8. And the second row of this table shows you that their bone age was delayed. Now, this isn't a surprise to us. We know that giving steroids delays your bone age. And most of these had been started around the normal time of starting steroids. So they'd been on steroids for just over 8 years by the time they started their testosterone. And again, I won't dwell on it, but they were on fairly typical doses of deflazacort and prednisolone. Next slide, please. So this was just the primary outcome, as I was talking about. And it's a questionnaire that the boys fill in themselves. And it has 14 items, which are grouped into 4 different categories. And it's gone a little bit funny along the bottom there, but hopefully you can see that there's different categories as overall treatment satisfaction, symptom relief, time to the actual drug working, how easy it is to use, how easy it is to plan the medication, and overall satisfaction. And we found that within the study, one boy unfortunately categorized it wrong. So he thought 1 meant excellent, whereas actually 1 was the other way around. So that was in the easy to use section, but hopefully you can see otherwise, everybody was either extremely satisfied or very satisfied with testosterone in terms of the different factors. Next slide, please. And I think just an important thing to mention here, and something that as a result of this study, we now talk to all the boys and their families about, because it takes a little bit to sort of get your head around, is that when you actually give testosterone to somebody, their testicles don't increase in size while they're on the testosterone, because obviously your testes volume is really a reflection of how much testosterone you're making, because they're largely filled with, cells that make testosterone. And so the testicular volume doesn't increase while you're on testosterone. We had a couple of the boys who were a bit surprised about that, but you can see hopefully from this graph here that the green plots on the right-hand side show that after we'd stopped the testosterone, so after they'd finished their 2 years of testosterone, 6 to 9 months after that, when we got them back in to examine them, their testicular volume had increased. And this basically means that the boys were starting to produce their own testosterone, which is exactly what we were hoping. Next slide, please. And in keeping with this, on the left-hand side, sorry, these are quite busy slides, but I'm just going to point out the key features to you. On the left-hand side, we've got the testosterone level, and the blue line horizontally going across is where we would hope that an adult level of testosterone lay. So anything above 8, really, we would be happy enough in a sort of population such as this. And hopefully you can see here that, again, the important one is that, giving injections increases your testosterone while you're having the injections, but also 6 to 9 months after, those levels on the whole remained at an average adult level. And in keeping with that, the gonadotrophins, now those are the hormones that are produced in the brain to signal the testes to work. And again, those sort of spurred into action after the testosterone was stopped. Next slide, please. So we also did, as part of our testosterone study, we did some qualitative interviewing of the 15 boys before, but particularly after their testosterone 2 years of intervention. And 4 of the key themes that came out from the interviews were, these young men want to be like their peers. And in particular, when they talked about that, they were concerned especially about their looks and about their height. So it wasn't just about how tall they were, but it was how old they felt they looked in comparison to their friends. And one of the things that cropped up several times in the interviews towards the end was they were so pleased to have been able to grow some facial hair because they felt it covered their, and I'm quoting from them directly, their hamster cheeks or their chubby cheeks. But they felt also that the beard gave them an obvious way for people to age them. And in keeping with that, they did talk about low self-esteem and difficulties in, being able to maintain friendships with their friends and difficulties communicating with their peer groups. And they felt on the whole that the testosterone had helped this, because they felt that it was aligning their way of thinking to that of their friends. One of the themes that also came out, which was interesting, was they tended to have implicit trust in us, in their healthcare providers. And that was quite difficult, because basically what they were sort of saying was, well, if you recommend testosterone, we'll go for it. And so it was actually quite reassuring that by the end of the interview process and by the end of the 2 years, they were still fairly optimistic about the treatment regimen, because they sort of admitted that they would probably have gone for it if it was something that the doctors had suggested. And I'm not sure that we always see that in our clinics, but this particular population, tend to be very stoical. And I don't know whether it's because we've built up a relationship, with these young men over the years, but they do seem to put huge amounts of trust in us, which, that in itself comes with, an expectation on us as well. Next slide, please. And so this was just a simple quality of life score that we carried out as well, which was questionnaire based. And hopefully you can see here that overall the quality of life score increased after treatment. But also what's quite interesting, I think, on this is that there are some boys whose quality of life decreased despite being on testosterone, although they all felt that it had helped them. And so, you could argue that this population are at a difficult time of their lives, and you wonder whether their quality of life would deteriorate still further without the testosterone treatment. Next slide, please. So this was just a little bit extra from the study that was quite reassuring, and I just thought I'd highlight here. So that this is from the muscle MRI data, and what you can see here is that the surface area of the muscles on the MRI increased during the testosterone study, not only just of the overall muscle, but also of the contractile muscle, so the healthy muscle. As during the disease process in Duchenne, the muscle gradually gets taken over and accumulated by fat, and then becomes fibrosed after that. But what we found was that, contrary to the normal at this age, there actually was a mild increase in the contractile muscle that you can see there, particularly in the last column there. That's the contractile surface area. So you can see the green was the start of the 2 years, and then the purple graph there, you can see the increase. Next slide, please. And also a little bit more of a surprise to us was the T2 relaxation time is another marker that you can look at on MRI. And this is used by researchers to give you an idea of the inflammatory process, or the inflammation in the muscle. And again, this showed the purple are the controls, so they're the healthy controls, and you can see that they're lower at all time periods. But hopefully what you can see is that the green bars are the 2-year data. And you can see here that in all of the groups, so we've got some of the arm data shown here, the T2 relaxation time was lower, so suggesting that there was less inflammation in the muscles after the 2 years of testosterone. And this goes with other studies that we've seen. You see similar in the beginning steroid treatment, for example, in Duchenne. And so this is suggesting that the testosterone might be having quite an important effect on the muscle as well. Next slide, please. So what we found with the initial study was, importantly, that these injections are well tolerated, and that the boys, they appreciated the opportunity to go on testosterone, and they didn't regret going on their 2 years of treatment. It promoted their bodies to produce testosterone themselves. I haven't shown the data because of time, but there was no deterioration in their bone density during the 2 years. And also we found this improvement on the contractile muscle bulk, which suggests that there might be an underlying benefit of testosterone on the disease process as well. So what we've done since then, in COVID made it very difficult, but we've looked at these boys again 3 years down the line. So next slide, please. And so what we've done is we've asked these young men to come back again. So 5 years after the beginning of the study, we've seen them for one final time, and just to really catch up and see where they are in terms of whether they need testosterone and how they're doing from a health point of view. So as you'll remember, they started off being 13, and by the time they had the final follow-up, they were nearly 19 years of age. So these young men have been on steroids for an average of 13 years by this point. And as you would expect, unfortunately, the number who are still ambulant has reduced, so that by the time of final follow-up, only 4 of them were able to walk. And you can see here that the performance of the upper limb, the PUL score, has deteriorated, but I'm told that this is less than would be expected in a 5-year period. And again, you can see that there was this stabilization of the bone density in the initial 2 years, but then this has deteriorated by the final follow-up. And this probably goes with what Jared was saying about, you know, how important it is to be, you know, to be walking to help your bones. And once in a wheelchair, we do see this steep drop off in your bone density. Next slide, please. And this is just, I don't think we need to go into this in a lot of detail. Can you just click? Because I think there should be some highlighted parts coming up. Yeah, so at the, at the final follow-up there, which is just circled on the right-hand side of that figure, you can see here that the testosterone levels, again, are maintained above that adult level. But what the table on the right-hand side shown, and unfortunately the colours haven't come up for some reason, but we did need to start 5 of the patients back on testosterone, and 1 had already restarted testosterone by the 5-year follow-up. So although those levels initially did increase after we stopped the testosterone, because of the continuation of the steroids in these boys, often they're not able to produce enough testosterone, and so we did need to restart them. Next slide, please. And again, this just shows, unfortunately, with the inevitable decline in the muscle function that we see in, you know, 18, 19-year-old men with Duchenne, that the improvements in the contractile surface area, so in that healthy muscle and in the fat fraction, weren't able to be sustained. And you can just click again, please. I think, yeah, so you can see on the left-hand side here, you can see an overall increase in the fat fraction by final follow-up. And if you click again, you can see a decrease in the contractile surface area. So next slide, please. So I'm not going to dwell on this slide, but what this has shown is quite interesting in that the boys continue to grow. And normally we would expect after the end of that 2 years of testosterone that the boys' growth plates would have fused in their bones and they wouldn't grow anymore. And that's what we tend to see in the healthy population. But probably because of the steroids and because of their slower growth, they still continue to grow. And you can see that the bone age, which is near the bottom of the table, they started at a mean of 9 years. By the end of the testosterone, it was 12 years. And by the final follow-up, it was still only 15 years. And if you remember, these boys are nearly 19. So this is suggesting that they've still got growing to do, which is important if we're thinking about strategies to help bone, particularly as Jared was talking about. So next slide, please. And this was just a little bit of extra work that we did as part of the study, which I think is important when we're thinking about puberty and about sexual health in these young men. And this inhibin B is really a marker of sort of Sertoli cell function. So this is one of the cells that sits in your testes and are, you know, important and responsible for reproductive capacity. And you can see here that inhibin B levels increased during the time that you're on testosterone, although the mean levels were below where we would expect for a healthy, you know, young man. We're getting respectable inhibin B levels, and this is very reassuring with respect to potential, you know, future fertility in these young men. So next slide, please. And just wanted to say that, you know, our findings have mirrored some of the small studies in both Australia and Cincinnati. And if you just click again, you can see in the in Mailan Rutter's group in Cincinnati that they also noticed with the testosterone that they found an increase in bone density and also stabilizing the fat mass, which we showed. And in the Margaret Zacharin's group, if you click again, please, they also showed again that they had an increase in bone density and that fat mass and lean mass were unchanged and that motor function improved in the ones who couldn't walk. So again, these are fairly similar findings from our study. So thanks. Next slide, please. So just to remind ourselves where we're currently at with the standards of care. So at the moment, what we're suggesting is that anybody who's 14 or older who has delayed puberty should be referred to an endocrinologist. And at that point, they should be, you know, have some simple blood tests taken to check that they are prepubertal, and that then they should have testosterone replacement initiated at a low dose and gradually increased over time, which is, you know, how we did it in our study as well. And what the guidelines say is it can be recommended for age 14 and over, but can be considered from age 12. And obviously we were fairly proactive in our study and found those benefits to muscle. So I'm fairly proactive in our cohort in Newcastle. That obviously depends on the family and the individual boy themselves and their readiness, but we like to see everybody by 12 so that we can start them if they'd like to at that age. Next slide, please. So where to next with respect to, you know, what we're looking at with puberty and sexual health in DMD? Well, we've been very lucky this year to get a grant from the Duchenne Parent Project in the Netherlands to carry out some focus groups to understand the views of these young men, looking at particularly sexuality and fertility in DMD, because it's important, obviously, that if we're going to be treating everybody with testosterone and giving them, you know, adult thoughts and adult needs, that we also are respectful and mindful of the fact that it can be difficult to have both emotional and sexual relationships, and you know, make sure that we are facilitating the views of these young men to find out actually what they want, and if there's any way that we can help them in terms of fulfilling their, you know, sexual health and their mental health when thinking about relationships and fertility. And we're wondering whether it's worth trying a trial of low dose, very early testosterone, so that it wouldn't actually initiate puberty, but in terms of to have an anabolic muscle promoting benefit. Thank you. Next slide. So I just want to thank everyone who's taken part in both of the studies, and Duchenne Now and Duchenne UK who funded those, and everyone else, and all my colleagues, and everyone else who has given their time and energy into these projects. Thank you.
Thank you really so much for this this presentation, also because I think in general very few people still speak about this subject in general when it comes to Duchenne care. So we are really happy that you were able already to present all this, and we'll do future work. I think that that's really relevant. And then we will, after the next presentation of Natasha Billy from Australia, we will have time for question and answers. And I already say that Dr. Saskia Houwen is still online. So for the question of Dr. Natasha Billy, who will speak about nutrition and weight gain, if there are any questions specific to that subject, Saskia Houwen will be there to answer these questions, as she has done studies on the same subject. So thank you so much. This is pre-recorded. Natasha is pregnant and lives in Australia, so it was not such a good idea to have her wake up in the middle of the night at 2 o'clock. We would feel too guilty, so we pre-recorded. So we're very grateful to her that she did this. Thank you.
Thank you for the opportunity to speak today. My name is Dr. Natasha Bilic. I'm an accredited practicing dietitian from Melbourne in Australia, and today I will be talking about nutrition and weight gain. Apologies, I can't be there live. It would be the middle of the night here in Australia. I'd like to acknowledge my affiliations up the top of the screen. So most of this work was done through Monash University, and I'm currently at the Murdoch Children's Research Institute. So today I will be talking about early weight gain in DMD and what might be contributing to weight gain and obesity. And then I'll discuss potential approaches to weight management. So it's well documented that children with DMD are more likely to have a higher body mass index, or BMI. So we collected some retrospective data in Australia here in Melbourne, and we found that the obesity prevalence at 5 years was approximately 17%, which then increased to 50% at age 11 years, where it peaked. And this is compared to about 7% of boys without DMD in Australia who have obesity. In this cohort, we also found that early onset obesity was associated with adverse health outcomes. So those with obesity were more likely to develop obstructive sleep apnea at a younger age and have their first bone fracture at a younger age. We also know from other literature that increasing BMI or fat mass is potentially linked with other adverse health outcomes for those with DMD. So reduced physical function, an impact on respiratory outcomes, as I mentioned, impact on sleep, metabolic complications can occur, and then, as I mentioned, bone fractures as well. What we don't know is what impact this has on psychological outcomes. So whether that may be self-esteem or a quality of life or mental health issues. We know from general populations of young people that weight gain and obesity is linked with those adverse health outcomes for those psychological outcomes. So it would be important to understand this in DMD a bit further. So what causes weight gain? So when you think about energy balance in general, in a very scientific way, the concept is quite simple. So if you eat more energy than what your body needs, you will gain weight. And then to lose weight, you just need to eat less than what you require. But it is really very far from being that simple, especially in the context of DMD. So we know that reduced muscle mass occurs in DMD, and this is going to affect the amount of energy that's needed at rest. Physical activity is obviously going to be reduced. So the most obvious reason is reduced mobility in DMD. But thinking more broadly, there may be other barriers to accessing physical activity, such as access to safe and appropriate activities or therapies, and especially in the context of those who may have a dual diagnosis of DMD and a neurodevelopmental disability or mental health conditions. For example, autism spectrum disorder, it may be more difficult to find appropriate activity options. We know that there may be lots of influences on dietary intake. So that might be related to mood or environmental factors. And I'm going to touch on these a little bit more later. And then, of course, steroids will have an impact on appetite, which will impact food intake. And not just steroids, but other medications as well. So whether that might be antipsychotics or antidepressants for those who have those dual diagnoses, as well as their DMD. And then overarching all of this is physical well-being, psychosocial well-being, and sleep and fatigue, which may influence all of these factors. So physical well-being may fluctuate. It may be, acute periods of, say, a respiratory illness, which is, of course, going to impact on physical activity. And then physical well-being may also decline with age as well. So it's going to be more difficult to participate in activities and make good dietary choices. We know that both positive and negative mood can affect dietary intake. And then sleep and fatigue can really have an impact on all aspects of life, including making healthier food choices and being able to participate in physical activity or therapies. So if we're thinking about energy expenditure, I think even though there's lots of factors that are going to influence it, it is important to understand it in DMD because it will be quite different. So this was a energy expenditure study led by Dr. Zoe Davidson, where she measured both resting energy expenditure and total energy expenditure and compared the results to age-matched controls without DMD. So the mean age of the cohort was 9 years, and I'll talk you through this. It's a little bit of a busy slide, I apologise. So for the boys with DMD at 9 years, the amount of calories needed at rest was approximately 1,200 calories. In addition, they needed another 50% on top of that for their physical activity, which totaled approximately 800 calories per day. And this was compared to 1,900 calories in the control group without DMD, who were also aged 9 years. You can see there's a little bit of a difference here, but of course, physical activity may not always be that extra 50% for those with DMD. It may fluctuate depending on what's happening in their lives. Of course, it's going to be dependent on the level of ambulation of that young person. We don't know what energy expenditure looks like in the non-ambulatory young people with DMD, but we can hypothesize that resting requirements will be lower than this 1,200 calories per day, because we can assume that muscle mass will decline, and that is what will mostly contribute to resting energy expenditure in DMD. We don't know what calories are needed for physical activity, but our estimates are that it could be an extra 10 to 30%. And so you can see that the total energy expenditure really does drop off to about 1,300 to 1,600 calories per day. And again, this is an estimate. We haven't actually measured this number. When you compare to the estimated requirements of a 13-year-old boy without DMD, the requirements are approximately 2,300 calories per day. So you can see there is a really big difference between those with DMD and those without. So the dietary recommendations are not going to apply for those with DMD, especially as they approach the non-ambulatory phase. So there's a lot of information here, but I think the key point to make is that as young people transition through the late ambulatory phase and then into the non-ambulatory phase, the amount of energy required is going to drop off dramatically. So to result in weight loss, energy intake would need to be much lower than, would need to be lower than that total energy expenditure. So this might be really quite difficult for the non-ambulatory young people, especially when considering all the complex factors, as I mentioned earlier. So I'm going to touch on some findings of a survey that we did in Australia, which explored barriers and enablers that influence nutrition and weight related behaviours in young people with DMD. And then we co-designed a weight management program for DMD. And it was a survey with parents or caregivers of who have a son with DMD. It was an online survey, and we sent it out to the whole east coast of Australia. You can see the states there across 3 neuromuscular clinics. The questions were guided by the theoretical domains framework, which categorises influences on behaviour. We had 53 participants. Their sons with DMD were at a mean age of just under 12 years, and just under half were reported to be above a healthy weight. Parents told us that the most common consequences of the weight gain for their sons was being self-conscious, having low self-esteem, and having low mood. And parents reported feeling worried and stressed. Some of the barriers that they told us about were fussy eating and sensory issues came out quite strongly, and increased appetite, mostly in all cases related to steroids, a lack of nutrition information in clinic that was provided. There was an identified knowledge gap in nutrition for DMD, and also just general dietary healthy eating principles. Time was a huge factor that impacted their ability to be able to prepare healthy meals, and stress about everything else going on in their lives as well. Screens were used at meal times, and we know that screens can impact the amount of calories eaten at a meal. So that was one of the barriers, and parents found it difficult to say no to their son because of their DMD diagnosis. On a positive note, nutrition was a really high priority for families, and weight management as well. They really understood the consequences of weight gain in terms of the health consequences. And there were some positive mealtime factors that came out. So they generally ate together as a family most nights. I'll just leave these quotes for you to read yourself. I think they're quite powerful. And we had some really good responses in the open text. So again, that theme of not enough information provided by health professionals did come out. So that's some work for us to do. So when I think of the barriers, I also think of potential strategies to address some of these issues. So I think overarching the strategy should be about starting the conversation early a conversation about preventing weight gain is going to be much easier and more positive than a conversation about losing weight, especially in that non-ambulatory phase when there is other priorities going on. So in terms of fussy eating and sensory issues, I think considering how much is going on for these families, we need to prioritise. So thinking about the most important things and just potentially focusing on one thing at a time. So probably the most important thing would be addressing any nutritional deficiencies. I guess there's the option of feeding therapy, but considering the time commitment that takes, I think it's going to depend on each family. In terms of managing appetite, even distribution of protein across the day, increasing fibre at each meal and snack, and recognising that real hunger versus steroid hunger. Health professionals, or particularly dietitians, should be giving practical nutrition advice that saves families time and stress, setting realistic goals around things like screen time, and acknowledging that weight gain is complicated, especially in DMD, and that weight management does become more challenging with increasing age. So setting some boundaries or setting up some healthy eating habits early is going to be much easier than trying to lose weight later on. So I said we co-designed a weight management program for young people with DMD and their families. And so this is the design that came out of that co-design approach. So it was a telehealth program, 6 weeks, intensive with weekly follow-ups and using motivational interviewing and goal setting. This was a really highly feasible and acceptable approach to weight management. The families really gave positive feedback. It was really well received and they felt like the telehealth model was really appropriate for them, avoiding travel, and they liked being able to participate outside of the routine neuromuscular clinic, considering how busy and how much information is usually provided in that clinic setting. They liked this program being removed from that a little bit. So in terms of future directions, we're hoping to scale up this weight management program and test the effectiveness of this in a randomized control trial. So we've been applying for funding to do this here in Australia. Dr. Zoe Davidson and I have been collaborating with Dr. Jared Wong in the UK, and we look forward to working with him in the future to do some more nutrition research in DMD. And then Zoe is leading the way with some further energy expenditure research, both in DMD and other neuromuscular conditions such as SMA. So I'd like to acknowledge Zoe for her guidance. She was my PhD supervisor and is leading a lot of this research, the neuromuscular team at the Royal Children's Hospital in Melbourne, and of course all the study participants from my doctoral research and other research in DMD. And I'd like to acknowledge all the families living with DMD. Here's my email. Please feel free to reach out if you've got any questions or you'd like to work together. We're always happy to collaborate with others. And thanks so much for your time listening, and hopefully the conference is a real success. Thanks so much.
So thank you so much, Dr. Billy, although you can't hear me now, but anyway, thank you very much for your presentation and being willing to step in when Dr. Davidson was not available. So now it's time for the question and answers of the endocrine session. We are a little bit over time, but I think we can still take some questions. And who would take the floor? Do you look yourself also into do you see the questions, speakers or panelists, or not? I can also read them for you, but so the first question is, can you briefly discuss the detriments of zoledronic infusion if they are received too many years?
So I can take that. So I guess zoledronic acid, once administered, needs to be monitored with bone density. That's absolutely essential, and you don't want bone density to be too high. In my experience, having given zoledronic acid to some of these boys for up to 7 or 8 years, whilst bone density increases, they don't actually even reach to the average or normal ranges. So that certainly is something that needs to happen. It needs to be monitored.
Thank you so much. Thank you. And then the next is, can one consider infusion for young DMD adults after spinal fusion surgery?
Yes, I think the question is that infusions for DMD boys after spinal fusion surgery, and especially if they're not steroids, for sure they can have them. But I guess generally we know that fractures and osteoporosis is commoner in those who are on steroids versus those who are not on steroids. So I would argue that it is likely that the risk to the skeleton is much lower, but if there's a need, if there are fractures, certainly they can be administered.
Thank you so much. And then I think the next question is, does it make sense to start a testosterone treatment on a DMD patient who isn't taking steroids?
Yeah, so again, that's sort of slightly similar to the last question. Delayed puberty is much more common in those who are on steroids. We know that the timing of puberty is also affected by chronic disease as well. So in our experience, we have had a couple of patients who have not been on steroids, who we've followed through puberty because they've started a little bit late, but they have managed to do it themselves. So we obviously would do a clinical examination and check testosterone levels before we consider starting testosterone treatment. But absolutely, there would be the same advantages of starting testosterone if they needed it, but they're less likely to need it if they haven't been on steroids.
Thank you. And then the last question from Yelena is the relationship between scoliosis and osteoporosis. So would you give bisphosphonates to prevent scoliosis in a boy without a history of bone fractures?
So certainly it seems like scoliosis and osteoporosis is different. So osteoporosis is related largely to steroids, although obviously muscles contribute to some of the bone fragility, but scoliosis is largely related to the underlying muscle condition. We do know that boys on steroids tend not to have severe scoliosis as compared to those who are not on steroids. So certainly bisphosphonate is not a reason to prevent scoliosis.
Thank you so much. And I think with this, we have come to the last question. So thank you so much also for this endocrine session. Thank you so much to all speakers today.
Can I just briefly interrupt? I do remember that we have another question by Carolina. She's one of our panelists, so this is why she couldn't put it in the chat.
Thank you.
Hello, I'm so sorry. I just wanted to ask Dr. Jared Wang about transition of care, of endocrinological care, and what is your uptake on it? If you have colleagues who follow same treatment, or if they switch to another drug or to an oral bisphosphonate, or if it's quite similar to your approach.
So I think, so that's a good question, and that's something that we're trying to address in the UK, and with collaboration with Ross and also with funding from Action Duchenne and Muscular Dystrophy UK. So the international standards of care, whilst it's meant to be all throughout a lifelong, with regards to osteoporosis, is rather pediatric centric. So for instance, in osteoporosis, in adults, there are probably about 4 other drugs that potentially can be used. So firstly, there's no evidence. And what we're trying to do is that with some funding, we're looking into the literature and actually developing some kind of like a UK consensus using a Delphi workshop type method with the hope that we'll have some output by 12 months this year. Currently, what I do in my center is just with close collaboration and discussion with my adult bone specialist, and I believe that's what Claire does as well. I think some of it really does depend on the resources, but we hope we can give some general principle guidance. It is not evidence-based with our new guidance that we hope we will release in a year's time from now, hopefully.
Thank you so much.
Thank you so much. So any more surprises? No, I don't think so, right? So then thank you everybody for this, who has participated as speaker, but also the audience, the people who asked the question. You're all super important. Tomorrow, same time, same place, 3 a.m. we continue with the second part of the conference. We will start with the newborn screening. We will talk about emergencies, about psychology, but also about psychiatry, so treatments with psychopharmaca. So we will have a fantastic program tomorrow as well. So please join us again tomorrow, 3 p.m. Thank you. And then Central European Standard Time. Thank you. Bye-bye.